So a very warm welcome to you all on this rainy London day. Thank you for joining us both online and here at King's College London. My name is Kristen Meager and I am the Program Manager for the Research for Health System Strengthening in Syria program, or R4HSSS, a fun acronym that I'm sure you'll hear many times today. And so I have the pleasure of welcoming you all today and thanking you all for taking the time to be here. Today marks the 5th Research for Health in the Syrian Conflict Conference, which started in 2018 under the Research for Health and Conflict in the Middle East and North Africa project, and that then led to this fully funded R4HSSS project. Since then, this conference has grown into a significant annual event, bringing together a range of organisations and groups who are all focused on health research in the Syrian conflict. This year, the conference is co-hosted by King's College London and the London School of Economics Conflict and Civic Research Group, and supported, of course, by all of our partners, USIM, MIHAD, the Syria Research Group, and the Syria Public Health Network. And of course, none of this would be possible without the funding from the National Institute for Health Research. Thank you, of course, to our excellent organising committee this year, comprising of all of our partners who have done a fantastic job in making today happen. Each year, the conference sheds light on some of the most pressing health needs in northern Syria, a region that we know has been impacted by more than 13 years of devastating conflict and humanitarian crisis, and in February 2023, a catastrophic earthquake. Research continues to play a vital role in presenting lessons learned for health systems in conflict in not only Syria, but globally. Health research in conflict-affected regions has been recognised as important to gain a deeper understanding of the actual needs of such populations, and to optimise healthcare delivery, as well as investigating feasibility and effectiveness of specific interventions. This, of course, informs policy and practice, and crucially, all of this advances advocacy for conflict-affected populations. So therefore, holding conferences like this, even where we may be physically far from the context, highlights not only the importance of health-related challenges in the wider humanitarian response in Syria, but also ensures that we continue to speak about the conflict and advocate for the best possible outcomes for people impacted both directly and indirectly by the conflict. Today we will be joined by a diverse group of speakers on various topics from infection prevention and control, breast cancer, and the response to the earthquake. And we also have a session dedicated to mental health. We hope that today will be an opportunity for you to learn more about the fascinating and innovative research that is going on in the context and ask questions. Each session will be introduced and moderated by a facilitator, during which time there will be an opportunity for questions and more discussion. For those joining online, I'm sure you're aware by now, you can watch the conference in either English or Arabic. And for those of you in the room, if you do want to listen in the opposite language that's being spoken, you will need to use your devices and earphones. Is that right? Yeah. You can also scan the QR codes on the program booklets if you want to read more about the presenters today. And refreshments will be provided across the hall. So today we're going to start with our keynote speaker, or our first keynote speaker, who is Professor Preeti Patel. Professor Preeti is a professor in global health and conflict in the Department of War Studies at King's College London. She's a multidisciplinary social scientist working at the interface of global health, armed conflict, and forced migration. She is primarily interested in improving the evidence base for health systems, health policies, and health outcomes for civilians affected by armed conflict and forced migration globally. She's also the co-director of the Centre on Conflict and Health Research at King's College London, and she currently manages the R4HSSS program here at King's College London. So thank you, and we'll hand over now.
just bear with us. We can't find our screen. Oh, we're back. We're back.
It's working? Great. Cool, that's fine. By talking about some of the highlights from the Research for Health System Strengthening in Syria program that's been going on since 2020. And thank you again to our funders, NIHR, but also the FCDO office in the UK and WHO for funding some of the related work that you will hear about. So what was the main focus for R4HSS? It was to create a model on health system strengthening in active conflict-affected settings. So many funders have funded programs in refugee hosting countries, in countries which we would consider post-conflict, but not in the most insecure, the most difficult of environments, and this is what we had in northern Syria. And at the same time that we were funded, so 2020, and sadly we come to a close in September in 2024, this year in a few months' time, we have seen, obviously, the conflict ongoing, the horrific conflict in Gaza, Ethiopia, Sudan, South Sudan, and many other places that have kind of lost the limelight. So there's some key questions I wanted to try and address as we move forward with the last couple of months of R4HSS and think about the future. Did we embed and enhance a culture, a research culture, and particularly amongst organizations, individuals who are really unfamiliar with conducting research? And I think that's a really key point, that there is much more interest in getting evidence from the places that are most affected by armed conflict. Did we address issues of inequity, capacity strengthening in our programs? Did we look at sort of who's marginalized, who doesn't have opportunities to conducting research, but also in terms of having policy influence? How sustainable, what's going to be the legacy of R4HSS? Of course, I would dream that it could continue for a very long period of time, but sadly, the landscape has become incredibly competitive. Did we address equal multidisciplinary partnerships? And I'll talk here about beyond this discipline to go on to think about working across different sectors, because I think the health system is important, but it just doesn't work in isolation. And then I'll address two issues around localization and the humanitarian peace development nexus, or the triple nexus, the two sort of areas that the humanitarian health community has been sort of talking about since the World Humanitarian Summit in Istanbul a few years ago. Our bread and butter issues are publications, and you have to have a lot of patience to get there with producing scientific papers in peer-reviewed journals, any journals, global health or any discipline. And so far we have 28 peer-reviewed journals, articles, and we have another sort of 15 or 18 under review or in progress, which will be completed in the next couple of months. Most of the research that we've done is qualitative, so there's been lots of people conducting research with key informants based in Syria and Turkey and Iraq and elsewhere in the UK, in Europe, US. And they've been conducting focus groups with groups that haven't been, targeted by the research community. And I think that's amazing, because it is very difficult to get to your population of interest. We're also seeing quantitative work with household surveys, and also analyzing secondary databases, be they aid databases, etc. So it's a combination, mixed methods research. We're seeing new frameworks, community health workers. That's a framework that's been used quite a lot from one of our publications, and we're seeing the adaptation of old frameworks. So everyone in the health systems world knows about the WHO building blocks. Those were published in 2007, and there's been a lot more work around thinking, are those applicable? Are they really thinking only about the supply side issues, and should they be looking at demand side issues, particularly from the health system users themselves? We've seen systematic reviews. The medical education work stream produced a number of systematic reviews, which have led to further work in Syria development and in the Syrian Board for Medical Specialities. What I think is outstanding in this group is that most of the publications are by Syrian and Arab authors from the MENA region. So lead authors, second authors, the teams, last authors, people from the diaspora, people in Syria itself, and across the region. And that's pretty different. If you look 10 years ago or 15 years ago, the trend was very different. It would be people who were based in the high-income world, telling the story of some conflict-affected place. You can't see to the right, but actually the bit that I wanted to highlight is authors from NGOs, the people who are actually collecting the data, working with the users, and also enabling the use of that data for research. And lastly, the point about Arabic. Now we're seeing a growing trend in the English language journals where you can publish a section of your work or the abstract in Arabic, and I think that will increase dissemination and outreach activities. Still a long way to go with publications, but I think it's as a whole, R4HSS has contributed quite a lot to a body of work around health system strengthening in a conflict-affected. When we were awarded this grant in 2020, it was the period of the first COVID lockdown. And many of us, led by Abdul Karim Exayez, put together a paper looking at the response and thinking about the community engagement that was happening in Northwest Syria, with very, very strong leadership teams across the region working on addressing the pandemic. This is one of the most cited papers from the Journal of Public Health, which is I think, quite striking. Don't worry, I'm not going to go through all 26 papers, but just to say that the latest of our additions to the publications is this really very, very understudied area of suicide. And I think this is one of the first papers from a conflict-affected paper on a highly stigmatized issue, and looking at sort of some of the factors such as living conditions, living in rural areas, and having relationship problems as contributing to this rising phenomenon of suicide. A key area of our work has been capacity strengthening, research capacity strengthening, but also health system capacity strengthening. How has this been enabled? Our PhD programs. This Karim graduating last year, having started from our initial R4HC MENA program and then completed while also leading the R4HSS program. Karim is a role model, a mentor to other PhDs. So we have other Syrians who are now joining us and have joined us to look at other aspects of the health system. We also have 2 female who are non-Syrians who are looking at other aspects of the Syrian health system, women's leadership, and the role of civil society, which are both very, very neglected topics. You're going to see a video from our Master's Scholarship awardees, which I think is a fantastic video that highlights the opportunities that these Master's Scholarships has given them. There have been tons of training workshops around clinical workshops, research methods, academic writing, scientific writing, proposal writing, as well as people actively disseminating their work in the region, globally, and elsewhere. and tremendous media engagement as well. The diaspora have been key. I don't think there's a diaspora from a conflict-affected place that is as fantastic as the Syrian diaspora. There is something incredibly unique and unusual, but I think they're a model for other diasporas from other conflict-affected countries on how to do policy influence, how to garner funding, how to respond in emergencies, whether it's COVID, the earthquake last year, cholera, etc. We're seeing so much around how to do localization better. This is a piece in the Financial Times by Karen von Hippel from the Royal United Services Institute, talking about reconstruction, rebuilding, early recovery being led by local actors. And how do we support those local actors? They have the willingness, but how are we going to sort of resource them better in order to do early recovery? We have PhDs, master's scholarships, looking at these hybrid, locally developed hybrid governance structures. A fantastic paper by Zaydoun and colleagues looking at the role of central desks. That's attracting a lot of attention, this debate around improving localization. We've also captured voices from local responders, local female responders during in the aftermath of the earthquake in Syria and in Turkey. We had a webinar around International Women's Day last year. We're also working across sectors. So this is representing civil defense. We're looking at engineering, looking at schools, and other education sectors as well, and creating new working groups as we go along in order to address those issues around building trust, building mediation, and addressing some of the huge power imbalances that perpetuate certain situations. Does this kind of model around hybrid governance apply in other conflicts? There's a Syrian delegation here to the left, invited to inform policies in Ukraine. And there are many other examples if you look at our newsletters around informing other conflicts, be it Sudan, Afghanistan, etc. More recently, we've been invited to look at the health system's thinking lens at the WHO MRO level. So some of us were invited to Cairo last year to inform this implementation guide for health systems recovery in emergencies. And all the usual suspects were there at the meeting in Cairo, the bilateral donors, the multilateral donors. But missing from that whole conversation were the health system users themselves and civil society. Not a single civil society group was invited. And that's often been the case with many of the sort of the dialogues and the implementation guides that you have available from larger organizations. So I think it's a process. It's a process of learning from these events and trying to think beyond the usual suspects. The future, I feel optimistic that we will continue our collaboration with the working groups that some of the R4HSS partners have worked with and will continue to work with. We're just doing the policy fellowships with the Knowledge to Policy at the American University of Beirut. Those will be completed, evaluated, and we'll have a network that comes through from those awardees. 17 master's scholarships, initially meant to be in person here in the UK, but because of COVID became online, and actually that became a very cost-effective way of doing and not draining people from the health system in Syria, so they could continue to work there, but also do a master's of their choosing in the UK online, and not in 1 or 2 years, but do it in as time worked for them. We're in early conversations around funding PhDs in collaboration with some of the NGO partners, also with EMRO and AFRO, as they look at the kind of early recovery in health emergencies across those two regions. Leadership schemes, the funders who are specifically interested in funding health system leadership schemes, so we're looking into those. And I think in the future, we sort of will have to look beyond Syria and think about comparative health systems with other places which have got similar crises, particularly this term polycrisis, which is used a lot to sort of think about multiple crises, this whole whole day is devoted to looking at health, but also disasters. And disasters, some of them are kind of responsible, the climate changes are responsible for some of those disasters, others are caused by other problems, political or social. So we'll have to look across the border, and I think we have a paper on our website looking at some of the cross-border issues around accessing health systems in different geographies. The rising burden of mental health, antimicrobial resistance, and non-communicable diseases, particularly as we're dealing with aging populations. So thank you for listening. The last point I want to make around having impact is that it takes a very, very long time. I know people feel quite disheartened when they get rejected by a journal because their paper didn't get through. But actually, when you sort of think about impact, this is collaboration that began in 2012, so more than 10 years ago. And I think it's important in sort of saying that there are small baby steps towards getting there in terms of getting large grants awarded and doing lots of capacity strengthening along the way. I hope in 10 years' time we have an even better story to tell in terms of the impact that we've had in strengthening the health system in Syria and in other places. Thank you. We have a video actually, sorry now, from the Masters awardees.
I'm honored to have been selected for this scholarship, since this scholarship is not just helped me in financial constraint that I have faced within my studies, but also have connected me to a network of passionate individual and professionals, and open a door for me for many opportunities to invest in my skills, expertise, and knowledge, and equip me with the knowledge that needed for the strengthening of health sector inside Syria. In Syria, there is an countless and a lot of talented and smart individual with huge dreams and aspiration, waiting for their dreams to be realized and recognized. But unfortunately, they have faced a lot of financial and barriers to achieve their full potential. So this scholarship holds a significance to empower them to succeed and make their dream as a reality.
So I graduated from the medicine faculty in Aleppo University in 2009, and then I have started my master study at the same university. I forced to leave my study because I was afraid of detention, and I left Aleppo to Idlib, and then I moved to live in Turkey. After that, I found that at Awesome Facebook page, they announced the R4H SSS scholarship, and thankfully I was selected for this scholarship. So the scholarship was online, and that was a great opportunity for us to learn from here and stay working for Syria. And it was a part-time, so it was easy for the health provider to continue their service provision to the beneficiary inside Syria without interruption, and also like having this opportunity to get this scholarship and get higher education. And at the end, like after I have been graduated, I'm now working as a specialist in sexual and reproductive health, supporting the SRH sector inside Northwest Syria. I think it's an opportunity to have a high education certificates, since there's no universities in multiple areas inside Syria, and also it considered as a foundation stone to build the health system, as we are focusing on support the human resources, which is one of the main part or pillars of the health system for Syria.
Sir Patel, just before starting the second session, I'm just gonna make sure that all our speakers are online. If you give me a second, Ibrahim is here. Just to make sure that our speakers have the ability to speak, because I cannot find Mohamed Hamze's. Have to allow him to talk. Second. Mohamed Alaa. Yeah, I'm just looking for Mr. Mohamed Alaa.
I'm here with you.
Okay. Okay, great. All right. So, thank you everyone for coming in person, and for our participants also, and the panelists online. My name is Mazen Ghariba. I will be the facilitator of the first session. Let me first introduce myself before introducing the speakers and the presenters. I'm a policy researcher at the Civicness and Conflict Research Group based at LSE, just across the street. Mainly, my work focuses on I primarily focus on Syria. We're part of the Syria team at LSE. We focus on multidisciplinary research and policy research on Syria, including the issues of civil society, legitimacy, transformative resilience, health systems, local governance dynamics, the private sector, small and medium enterprises. So we're really trying to approach Syria from different angles. Personally, I focus on civil society, local governance, and the issues of resilience. However, I also I have some experience on working on the governance of the health sector in Northwest Syria. In this session, we have 3 presenters. But first, I just want to just reiterate some of the housekeeping rules. So each presenter will have 10 minutes each for their presentations, and then we'll have a half an hour facilitated Q&A from the audience here and online. I will start by introducing all of our presenters. The first presenter is Dr. Ibrahim Bou-Orm. Dr. Ibrahim Bou-Orm is a medical doctor with extensive experience in global public health research and practice. He is a lecturer and teaching lead at the Institute of Global Health and Development at the Queen Margaret University at Edinburgh. Before that, he worked for the Lebanese Ministry of Health as a public health consultant on non-communicable diseases, prevention and control, and refugee health in 2017. Dr. Ibrahim's current research focuses on analyzing health systems in fragile and conflict-affected settings in the Middle East and North Africa. He has also co-authored more than 30 peer-reviewed publications. He's also co-leading case studies on integration of refugee health systems as part of a research project with UNHCR. Our second presenter is Dr. Mohamed Hamze. Dr. Mohamed Hamze is a Syrian dentist with a master's degree in health sciences and currently works as the research manager at the Syrian American Medical Society, SAMS. With a deep understanding of evidence-based advocacy and humanitarian response in conflict-affected areas, he focuses on healthcare access and utilization in conflict, protection of health workers, attacks on healthcare, violations of international humanitarian law, and health workforce dynamics in conflict. And last but not least, we have Dr. Mohamed Alaa Ahmado. Dr. Mohamed is a dedicated researcher and experienced professional in the field of infection prevention and control. He holds a bachelor's degree in pharmacy and a master's in laboratory diagnosis. He is currently a PhD candidate in medical biology at the medicine faculty at Erciyes University. I hope I pronounced that correctly. He has 7 years of work experience in Northwest Syria, focusing on IPC and drug control. He has further expanded his expertise over the past 2 years in Northeast Syria through his work with the Erbil office of the Medad mission. In his current role, he serves as the head of Quality Control Department, which includes the research, IPC, and medical commodities sections. I will start with you, Dr. Ibrahim Bou-Orm, if you can hear us.
Yes, I can. Thank you so much for the introduction.
Thank you. The floor
I'm not
is
being
yours.
able to share, to start my video. Maybe if I can get access to that, I'm happy to share the video as well. But I think I can still share my presentation.
Let me try to give you permission to do. I think.
Yeah, that's fine. I think now.
Yeah.
Can you see the presentation?
Yes, we can.
Brilliant. Thanks so much, really, for the introduction, and thanks for this opportunity to present our work at Queen Margaret University as part of the Rebuild for Resilience Consortium on Health System Resilience, based on different studies that we conducted in northern Syria and supported by different partners, including WHO, MIHAD, and other partners. And apologies again for not being with you in person this morning due to personal commitments. In this presentation, and I think I'm clear to go, right? I'm clear to present, so I'm just going ahead with the presentation. So in this presentation, I will reflect on health system resilience, as I said, based on multiple studies exploring specific elements of the system, as I'll explain in a couple of minutes. But I think before, especially since it's the first session in this very important research day, and to have some background information, it's always relevant to remind ourselves of the extreme fragility and the extreme level of fragility of the context of northern Syria. So starting with the chronic stressor of the conflict itself, we just started this year, the 14th year of conflict. As you can see from this YouTube video from The Guardian, the infrastructure in northern Syria is severely damaged, especially after the earthquake, at a time when there is an increasingly constrained funding for humanitarian assistance. So the decade and a half of conflict witnessed many waves of displacement as a consequence of the conflict. And the northern region is now home for at least 3 million internally displaced people. On top of that, we've had other multiple shocks in the recent years, such as this recent earthquake. And the video here shows the scale of destruction from the earthquake that happened back in February 2013. And for instance, as an example, the cholera outbreaks are one of these examples illustrating additional interconnectedness between the very bad infrastructure and its impact on health. Syria also, and specifically the northern part, has a complex political and military dynamics, and with different set of actors involved and issues of legitimacy of authorities, which may be recognized by part of the international community, but labeled differently by others. And we know all the story of having really challenging ability to identify sometimes legitimate authorities in different settings, and legitimate by whom, for whom, and so on and so forth. And the colors on this map from October last year show such complexity, and the situation is not stable, as some of these lines, such the red one, kept on moving upward, and all the challenges in also somehow trying to identify what the kind of the internal borders of different regions, and at first having, unfortunately, borders within the same country. As for the aim of the talk and the source of data, as I said, I'll provide reflections. Really, it wasn't a one study on resilience, but it was based on research studies that we conducted in collaboration and with financial support from WHO, the Alliance for Health Policy and System Research, in collaboration with the Field Office of Gaziantep. Other studies were supported by MIHAD, Acts Awesome Friends, and other partners over 2 years. So the first one looked at service delivery at an integrated service delivery network in Northwest Syria using a mixed method approach. I'm trying to avoid the details of the methods for the sake of time. The second one looked at MHPSS, the mental health and psychosocial support, using similar methodology, combining group model building workshop, semi-structured interviews, and surveys with beneficiaries and community members. And the last two studies, which are yet to be published, examine private sector engagement, looking at the role of the private sector in northern Syria, but also healthcare utilization across the public, private, and humanitarian NGO sectors, to see preferences, availability of those different sources, and then preferences of communities. On what I might call them findings based on these different studies, and as you've seen in the video, it's not just the video didn't focus on the first few years, but if we want to remind ourselves of what happened in the northern Syrian context, the first few years of the war were characterized by consistent attack on the health system. So colleagues, I know they wrote extensively on the weaponization of healthcare, noting at least having 600 attacks and hundreds of health providers unfortunately killed in just a few years, leading to the collapse of the public sector. So this is how we're trying to start seeing what happened in terms of the infrastructure of the health system, especially in the West. To fill that gap, and this is part of our first study, the NGO sector emerged and created a coordination mechanism to mobilize resources, focus on essential health packages, and also being able to provide at least essential services to vulnerable communities. So that network started near Idlib in Sarakib, and then moved up to the borders with Turkey due to the military attack and the people movement. And this is, as I'll reflect later, it's kind of a resilience capability of this system. This network, which was supported by various donors, coordinated by WHO, led by local implementers, started with a pilot of 10 facilities before having at least 30 facilities over the years, and it managed to work towards standardizing inputs, processes, reporting mechanisms, and so on and so forth. And we consider it as a seed model of care for post-conflict recovery. But the third study that I'll mention in a second revealed risks to this model because with the improved economic activity in the region, especially in the east, and dual practice leading provider to shift away from the NGO sector, this model as a feature of health system resilience in northern Syria is somehow threatened. The network, just quickly, some features on its effectiveness. It improved health coverage, reaching its target of 30% increase in health coverage, improved access to some services, including reproductive health, but also NCDs, despite the overall level of NCD services, as you may know, and also the NCD outputs remain low across all the region. The same approach by health actors was applied to mental health and psychosocial support. So, for instance, in 2018, a technical working group for MHPSS was created, did an assessment of the needs among community members, but also health workers, and they've put in place some elements to respond to the needs, including, for instance, training non-specialized health workers, improving medicine availability, and again, those are examples of adaptive resilience capacities of the system. But unfortunately, some of the limitation of funding, for instance, the short-term funding and the nature of the funding being intermittent, including to the severe shortage of specialized health services, specifically for mental health, remained one of these key issues affecting the scale-up. We were able, and I'm not going into the details of this, but we were able to map really the dynamics of the MHPSS response in one of the papers that we published it was published actually in Conflict and Health. We managed, for instance, to link some of the impact of this work and this MHPSS response on reducing stigma, improving outcomes for health workers, but also community members. So in addition to funding and HR issues related to NCDs and mental health, which I just mentioned, we identified across all research studies challenges at the broader level of the health system, including fragmented stewardship, limited organizational capabilities of local health authorities. Because despite having or not a clear governance framework, we need some people on the ground to be able to enforce or implement those policies and so on. And that was a major gap, especially between different regions and who's reporting to whom, and with the border in Turkey, who's for instance, the main, who's having the main leading role, and so on and so forth. And also we witnessed, or we reported, a lack of and oversight, I would say, over the whole health sector. We know that some really directorates are present, are doing a great job in terms of supporting the system. But in a sense, when I speak about specifically the private sector, you can see that there is an unregulated growth of the private sector with somehow a selective provision of profitable services and inequitable access among community based on their socioeconomic status and other characteristics, leading to our understanding that there is a gap there to be able to regulate the private sector. We found in the last survey, which we did across both the East and the West, and at least targeting over 1,200 respondents, and it was a household survey, a high but inequitable utilization of private services. And I would say, especially in the economically better off East, suggesting what we called it a pro-rich distortion of the health system, similar to Lebanon, the semi-private service in Iraq, and so on and so forth. So we were able to identify those gaps in how the system might be distorted over the years, especially now with the somehow stability in terms of, like I would say, conflict at the conflict level. But unfortunately, other resilience elements such as emergency preparedness, strategic planning, and data use remain somehow limited. Although I know some other colleagues, especially the R4HSS, they publish a lot on the positive aspects of how this network of service delivery and other actors managed to work on emergency preparedness in relation to the COVID-19 pandemic. So just to conclude, and I think I still have less than a minute, despite a fragmented context, and infrastructure issues, the system in northern Syria showed some adaptive but also absorptive capabilities, including this seed model of care for the future and effective also coordination mechanisms between non-state actors to be able to fill the gap at different level, at strategic, but also and specifically, at operational level. However, human resources in terms of availability, but also the emerging dual practice now and other challenges may risk undermining these resilience capacity. And of course, we can still reflect on this based on more interesting studies from colleagues, as I said, in the room. Thank you so much for listening, and thanks to all partners involved in the different studies, including, as I said, the support from different organizations, St. Joseph University of Beirut, Midmar in terms of support, but also to our Rebuild for Resilience project supported by the FCDO for supporting some staff time and publication of these bits and pieces of work. That's me. Thanks so much.
Thank you, Dr. Ibrahim. Thank you so much, and I'm sure many of our attendees would love to engage with your findings in the Q&A session. And thank you for keeping the time. Now I will give the floor to you, Dr. Mohamed Hamze. If you can also keep your presentation within the 10 minutes limit, that would be great. Dr. Hamze, the floor is yours.
Thank you, Mazen. Let me try now to share my screen, but I think I would need authorization to do so.
All right, just how can I do that? You should have the permission. Trying to make you a co-host, just 1 second.
Okay.
For some reason I can't find you here. I'm trying to find you here. Here you go. Can you try now, Dr. Mohammed?
Yes, I think it's working right now.
Okay.
So, do you see my screen right now?
Yes, we can.
Okay, so I'll try to make it a full screen. Well, Mazen, thank you again. Good morning, everyone. It is my pleasure to be with you today at the R4H SSS annual meeting. My name is Mohamed Hamze. As Mazen said, I work with the Syrian American Medical Society at the research department. Today I will be talking to you about this recent research project soon to be published at the BMJ Global Health in collaboration with different academics from Imperial College of London, notably with Dr. Alaa Ahmado, head of our research committee at SAMS, and also with our other committee members, including Vinay Kampala from the University of Pennsylvania, Maya Tarnas from University of Irvine in the United States. So without further ado, let me start to talk about the framework of this study. Let me say that at SAMS, we were having an increased interest in analyzing and understanding the health services utilization patterns in all of the areas. Oops, it's automatically changing. Sorry, I'll try to make it not doing so. In the areas that we are working, basically in Northwest Syria, where there is an active conflict. In order to do so, we were trying to focus whether on segmenting our work according to different medical specialties or according to different demographics. Vulnerable groups, especially children, had a lot of interest from our side because naturally they are more vulnerable among other groups to conflict, and also because of the increased numbers of children, unfortunately, living in conflict settings all over the world, and also in our areas. I mean, almost about half of the displaced persons, 6.4, 6.5 million IDPs in Syria are among children. We are seeing an increased numbers of children. More than 4.5 million are becoming food insecure. Over 2.5 million are outside of schools. I mean, many things are affecting their lives, and the conflict itself is affecting, whether directly or indirectly, the morbidity and mortality of these children, and having a various number of diseases affecting them. With that being said, unfortunately, the ability to conduct quality research in a humanitarian setup is always challenging. Fragmentation of health system and difficulty in getting proper data is always difficult. I would say we were happy at SAMS to be able to work on improving our information health system in the previous period and being able to extract some useful data to be analyzed even retrospectively to quantify, some of the effects of conflict on health services utilization among children, at least in our centers of operation between 2018 and 2022. When we are collecting these data, we were using the ICD-10 standard for a classification of diseases. So at the end of the day, we ended up grouping them into four main categories to ease the study. We collected the different pathologies that we were able to document under whether trauma-related conditions, infectious diseases, and vaccine-preventable diseases, NCDs, and the mental and behavioral disorders. And also, finally, the last category included nutritional-related disorders. Actually, the overall number of consultations we had was over 3.5 million pediatric consultations from more than 51 centers of SAMs working in this area. Almost 60% of them were in Idlib. But for the sake of the study, we removed almost 1 million and ended up with 2.6 million that only and solely falls under these categories. And in order to analyze the impact of the conflict, we provided data coming from the UN OCHA, maybe HNAP as well, for the displacement information, in order to be able to do a multivariate logistic regression between the different categories of consultations and the displacement itself. Actually, to be more precise, we built a model that takes into consideration other factors as well, including, for example, the age, sex aggregation, the host or IDP status, but we ended up showing mainly the displacement data. And also, when we were doing that, we wanted to assess the impact of conflict on on consultation by consultation type, not only at the immediate occurrence of the displacement itself, but we had different time lags right away after the occurrence of the incident itself. And then we took another time frame after 1 month, after 2 months, and after 6 months. We were experimenting with these, time lags with our model in order to find something that is useful and that is adjusted according to the other variations, as I mentioned. You can see all of this in more details in the study when it is published. Today, I will only be showing this in the immediate occurrence of the displacement and after 6 months. So when you look at the association between displacement and trauma conditions and NCDs, and here also, maybe I forgot to say that when describing the methodology, displacement are not equal. So we also had to differentiate between low level, okay, how to go backwards here, low level of displacement, which was by definition less than, in our definition, less than approximately 24,000 displacement movement per month. And the medium displacement was sometimes between 24,000 to almost 50,000 per month. The high is anything that is upper than that and lower than 80,000 per month. And severe is anything that is more than that. We took this low displacement as a reference to compare the adjusted odd ratio for the other levels of displacement according to the different category of disease. And as you can see, displacement was always associated, with an increased odds for a trauma-related consultations, something varying between 15 to 21% increase that has been persistent even, in a 6 month lag, even though, there has been a gradual smoothing toward one back again, but we were able to, it was noticeable that this association was remaining significant after 6 months lag. The same happened with the NCDs, also at 0 and after 6 months, almost between 10 and 19% increase in the number of consultation for NCDs.
2 minutes, Mark.
10 minutes out?
2 minutes.
2 minutes, okay. Nutritional has the remarkably the highest value of increased odds for consultations. You see that we were even ranging between 31% increase and up to 70% at the immediate occurrence of displacement. And these numbers remain significantly interestingly high after 6 months. In the details, these associations was higher with children who were under 1 year's age old, naturally, and the association decreased with the increasing of age. Surprisingly, and in contrary to what we were seeing, infectious diseases model that we were able to collect shows a less odd associated with displacement, which means there has been a decrease in accessing infectious diseases consultation, which is in contrary to many studies, that has been, present in similar contexts. I will not go into seasonality relationship right now, but what I want you to remember from this session is that usually displacement is associated with an increased odds for consultation among all groups for different kind of categories, whether it's for nutrition, whether it's for NCDs or for trauma, where we were seeing a decrease in consultation for infectious disease. We believe that, maybe you can answer this further in the questions, but there is a need to study that into further detail in order to be able to customize, our health response programs in a way that is suitable and sensitive to the context that we are working for in Northwest Syria, and maybe support that with additional qualitative research, maybe with the patients and healthcare provider to understand and see whether, our findings are precise. And hopefully this will open the door to further studies to understand the association between the conflict factors and pediatric consultations in conflict in Northwest Syria in particular. Thank you very much.
Thank you so much, Dr. Hamze, and thank you for keeping the time. Now I would like to give the floor to Dr. Mohamed Alaa Ahmado. Dr. Mohamed, I hope you can hear us.
Yeah.
We can see your presentation. Thank you. Also, you can start, and may I remind you, you have 10 minutes for your presentation. Thank you.
Yeah. Thank you. First of all, thank you for hosting me at this great and unique conference. This is Alaa Ahmado. I'm the head of quality control department in MIHAD Erbil mission. Our department consists of research, IPC, and medical community. Let me start with the title of our research. Our research about infection prevention and control in conflict-affected areas in Northeast Syria, a cross-sectional study. This study was conducted by MIHAD organization, as I said, the Erbil mission, and funded by King's College London through our 4HSS project. And our research team consists of me as a research leader and Dr. Muaz Ghajar, Kristen, Preeti, and the supervision of Dr. Karim Zayed. Let me start with the little background for the IPC. The IPC, Infection Prevention and Control, is a clinical and public health specialty based on a practical and evidence-based approach, which prevent patient and health worker from being harmed by avoidable infection during the provision of health care. As you know, as we can see here in this figure from the Lancet Journal, IPC is the essential component of universal health coverage. In addition to that, IPC is the main pillar of any outbreak response plan. The IPC, the health system, any health system, there are 6 components of any health system. And the IPC overlaps directly with the service delivery component and secondarily with other components. And to emphasize the role of IPC, let's remember something important. Infections knows no border, and the health facility may act as an amplification point of infections, as happened in West Africa before 2014 during the Ebola epidemic. Our study focused on two levels. The first one is about the first one. Our objective is to study the in-depth assessment of a representative sample from the health sector. Our assessment related with the infection prevention and control system in health facility. And the second level was about evaluating the hand hygiene program in this facility. You know, the hand hygiene is a cornerstone of IPC. And according our literature, according to the literature review and our knowledge so far, I think it's the first study of its kind in the whole of Syria, focusing on this in-depth assessment. For the methodology, the selected area was in Northeast Syria. I mean, for Governorate, Deir ez-Zor, and Hasakeh, and Raqqa, and Aleppo. For the selection criteria for the health facility, we have a multiple selection criteria like geographical distribution, stakeholder, and health facility type. We have a PHC and secondary healthcare, primary and secondary and tertiary healthcare. And we have a public health facilities, not private one, supported by NGO or local council. This is the distribution of our health facility targeted. The total number of health facility was 33. Almost half of this health facility are hospital, and the other half distributed among primary and tertiary healthcare. For the geographical distribution, we have 40 in Deir ez-Zor and Raqqa, 12 in Hasakeh and Aleppo. For the tools, we have used two tools. The first one is the Infection Prevention and Control Assessment Framework from WHO. This tool consists of 8 components. And the second tool, Hand Hygiene Assessment Framework, it's also from the WHO. It's consists 5 components, and we have for each tool we have classification for each health facility as inadequate, basic, intermediate, and advanced. For the data collection, we have three field teams, and we have signed a MOU with the local authority. And this study took place in last year, April and May 2023. For the result and discussion, let me start with the most critical result. The first one, when considering the WHO IPC minimum requirement, over 92 of health facility, 30 out of 33 didn't meet even half of the WHO IPC minimum requirement. And the importance of this result becomes appear when we compare it with another study, other comprehensive global study of 5,000 health facilities around the world. 81 countries in 2019, which only 7% of health facilities still need to meet half of the WHO IPC minimum requirement. The second finding, when we look at the type of health facility, we find notable gaps in adherence to WHO minimum indicator. However, primary healthcare show better adherence compared with the secondary and tertiary healthcare. For the classification of health facility, following the first tool, we have a bad situation. We have 82% of this health facility classified as inadequate. Only 18 rated as basic. and none achieve intermediate or advanced level. For the IPC component, we found that the lowest score was the first and fourth component, IPCI program and healthcare-associated infection surveillance. We didn't have any surveillance system in these facilities, followed by the fifth and third component. This result highlight two potential areas that require urgent attention or resource reallocation. On the other hand, we have highest score in the 8th component and 7th component. All donor in this component, include personal protective equipment, PPEs, and as you know, all donor and NGOs just focus on this point. I believe it's the time to change our traditional ideas about IBC that are deeper than just temporary PPEs, and I think we must invest in permanent component according to our phase in sustainability for health system. For the second tool, the classification was 34% classified as inadequate, and the majority, 66, as a basic. For the component, we have the safety change and institutional safety climate. It's a good and high media, but the domain of training
Dr. Alaa, you
and
still have 2 minutes?
Yeah. But the domain of training and education and performance. For the recommendation, the first one is prioritize the WHO IPC minimum requirement. Based on our result, we find it urgent to upgrade the NS healthcare facility to meet global standard. For the second one, invest in IPC education and training. For the third one, I think it's a very important recommendation, because so far there is no health care associated infection surveillance system. Not for community diseases, but for healthcare associated infection within the health facility, like surgical site infection, bloodstream infections, or methicillin resistant staphylococcus, MRSA. I think it's a very critical, especially when we talk about that this infection, up to 51% of this infection are resistant of antibiotics. For the third, it's a pollster for hand hygiene initiative, and to build on the strengthen and to encourage more research. Finally, to encourage more collaboration. Finally, I would like to point out that this assessment is a part of the whole project that include developing this health facility by focusing on IPC component. That's all from my side. Over to you.
Thank you so much, Dr. Alaa, for your presentation, and of course for all the presenters. So since we started a little bit late, we're supposed to have a 10 minutes coffee break, but since we started late, so we're hoping that we can jump directly to the Q&A, and of course you guys are free to go and get your coffee and then come back. So I'll start with the Q&A, taking questions from the audience here and of course from our audience online. My colleague Benazir also will pass the mics. So if I may ask you, when you have a question, a remark, a comment, a feedback, just also maybe present yourself and your affiliation, and maybe direct your question to one of the presenters. So anyone who would like to start with questions, comments, remarks? Yes, please. And of course, for our online audience as well, I will be monitoring the screen for any questions.
Hello. Thank you. Good morning, and thank you for the speakers for interesting presentations. My question is to Dr. Mohamed Hamze. First of all, sorry, I didn't introduce myself. My name is Loujain Joudi. I'm a pediatrician from Syria, Damascus, and I've recently finished my master's in global child health at UCL. My question to Dr. Hamze, when you mentioned the displacement categories, I'm sorry, I might have missed the idea, but can you please clarify the categorization of the displacement, like the classification, low, moderate, severe, high? Thank you.
Thank you so much. I will take 2 more questions before going to the second round of Q&A. Any other question, comment, feedback, remark from the audience here? Yeah, Manar, please.
Hi, this is Manar Marzouk. My question is to Dr. Alaa. So he mentioned that there is more research is needed, but I'm interested to know in which area they found there is a need of research.
Thank you so much. Any other question? All right. Not so far. All right. And I think we don't have any. We do have some Q&A. Okay, so these are not Q&As. People are just having some technical difficulties. All right. So far we have 2 questions. The first question is for you, Dr. Hamze. Dr. Hamze, can you hear us?
Yes. Yes, Madam, I'm with you. The reason why we made these different displacement level is that we were having this theory about, the dose effect level per se, when we are subjected to different intensity of displacement. And in order to do so, we looked at the data coming from OCHA, and we aggregated them per displacement per month. And then we agreed on 4 levels of displacements. The lowest one is for any months where we were having only less than 24,000 movement of displacement at that particular month. The medium one is between 24 to 48,000 per month. And the high one is between 48 up to 80, and severe is anything over 80,000. And as you can see from the result, there is indeed a difference in adjusted radio associations based on the intensity of the displacement that has been observed and the duration upon which this effect is happening.
Thank you, Dr. Hamze. The second question was for you, Dr. Alaa. I hope you were able to hear the question.
Yeah. Thank you for your question. In recommendation, the need in Northeast Syria. We know all of us the conflict area didn't contain very much research, but I think Northeast Syria, comparing with Northwest Syria, didn't contain any research about infection prevention and control, about outbreaks in this area. The Northeast Syria, especially. Thank you.
Thank you so much, Dr. Alaa. Any more questions from there? Okay, so before going to another, there's a question there. And see.
Thank you. My name is Sara Seta. I'm the Operational Research Manager for the Mentor Initiative. My question is for Dr. Hamze. I would like to know your thoughts on the fact that the consultations of infectious diseases decrease compared to the other pediatric consultations on trauma, nutrition and non-communicable diseases.
Thank you. Thank you. And we also have a question from Manar.
Hi. I have another question for you, Dr. Alaa. Is about, so you mentioned that 92% of health facilities in the Northeast Syria, they don't meet the requirement compared to you, and you compare it to the 77% globally. So I wonder, how is it like? Did you look at comparing it as well with the situation in Northwest or government control area, and if there is any studies already done around this? Thank you.
Thank you so much. Dr. Okay, so we have a third question before going back to the speakers, please.
Sorry, just to follow up from my colleague's question, the 7% from the rest of the world, I'm just interested in knowing where exactly and whether what level, is it in low and middle income countries, conflict affected countries, or just first world countries? Okay. Thank you.
Thank you so much. I will start with you, Dr. Alaa, before going back to Dr. Hamze. I hope you heard the questions.
Yeah. For the first question, as I said, we didn't have any studies, any research from the Northeast Syria in this regard. This is for the first question. For the second question, the 7%, it's from comprehensive, another comprehensive study, which include 5,000 health facilities around the world in 81 countries, and 7% of this health facility didn't meet even have the IPC minimum requirement from WHO.
Thank you, Dr. Alaa. Dr. Hamze?
Yes. So the results related to decreased odds for infectious consultation when associated with displacement was honestly one of the riddles that came out in this study. And we tried to explain that in different ways. But to be honest, I think none of the explanation could be completely satisfactory, and this is why we suggest that maybe more studies could be useful to double check the findings of our work with this limitation, as for example, coming from a single NGO working in the area. And while SANS has a good footprint in the area, but at the end of the day, I think we were covering approximately 20% of the overall consultation in the area. But what we were trying to maybe to explore is, the nature of other consultations, for example, NCDs, that require more or less a constant supply of medication, which could, to some extent, justify why you wouldn't, see a decrease in these consultations, on the opposite, an increase when people were no longer able to carry on their medications with them. And seeking, the access to the health centers while there is an active displacement. The theory that access has decreased wasn't satisfactory enough, because when we looked at the overall number of consultation together, the number of patients remained stable. It's only the composition of consultation that were going more in favor towards nutritional consultations, for example. Some other factors could be there, could be sometimes even any anecdotal lack of, medications that are related to treatment of infectious disease at this period of displacement. We are not sure about that, but this could be, a possibility that also need to be explored. We need also to understand the role of mobile clinics that is circulating in the area at that time, and maybe if there is any change of healthcare provision patterns that are happening at that time. There are so many variables that could eventually explain that, but we found that this is an interesting thing to be mentioned and shared with the larger group. One last comment, because I didn't have the time to touch on, is that we tried also to explore association with seasonality, I mean, different seasons of the year, and also with displacement. For infectious diseases in particular, there was an increased odds for accessing care for infectious diseases in winter naturally, while we were having an increase for the other categories during summer. In another paper that we published on respiratory care last year, most of these cases are usually associated with RTIs or respiratory infections, and notably also within the younger ages of children. So, I mean, as you can see, I mean, it's a multivariate environment where there are many factors affecting these trends, and maybe we need more studies to get a full picture. Over to you, Mazen.
Thank you so much, Dr. Hamze. Before concluding the first session, just one last check if any more questions or comments from the audience. Here, no, and online. Okay. Thank you so much. If you can just round of applause for our presenters. Thank you. Thank you so much. And now we will move to our second session with Manar as a facilitator.
Second. Yeah, now. Yeah, okay. Hi, everyone. My name is Manar Marzouk. I'm a research fellow at London School of Hygiene and Tropical Medicine. My expertise is research on non-communicable diseases in emergency settings using qualitative research methods and mixed method. Last year, I led qualitative research about breast cancer experience in northwest of Syria, and today my colleague Bushra Al-Amin, she will present it. At the moment, I'm working also on a qualitative as well research about the switch from human insulin to analog insulin in Tanzania and Bangladesh. And I'm also a member of several centers and networks like Syrian Public Health Networks and Center for Global Chronic Conditions at London School of Hygiene and Tropical Medicine. Today, so the same rules applies like before, as my colleague Mazen mentioned. So each presentation will be 10 minutes, and then we will have time for questions and answers. So first we will start with the presentation by Ayla Alkharrat. Ayla, just to check if Ayla, can you hear us? Oh, she's here. Oh, okay. Yeah. Hi, Ayla.
Hi.
Yeah. So yeah, just quick introduction about Ayla. She's a Middle East Program Officer at the Mentor Initiative. She's a global health specialist with educational background in clinical pharmacy and health and international development. She has extensive experience in managing community-based health programs and building resilient health systems within humanitarian settings. And she worked on several pillars under global health, including primary health care, health system strengthening, integrating community-based disease management. And her technical expertise encompass multi-sectoral approaches and interventions, including public health, nutrition, MHS, PSS, WASH, etc. We're very happy to have you. Thank you very much.
Thank you. Okay, perfect. Thank you, and hi everyone, thanks for joining. I will be presenting on humanitarian aid during prolonged conflicts and its effects on primary healthcare in Syria. The research covers government of Syria controlled areas, although some of the findings may be cross-cutting. We'll be starting with a brief overview of humanitarian health aid during the conflict in Syria. Between the years 2012 to 2023, large amounts of emergency funding was received, with the health sector consistently being among the most highly funded sectors. However, as we can see in the graph here, the gap between the funding needed and the funding coverage increased drastically after 2019, with funding coverage reaching only 13.3% at the time of conducting this research in 2023. Over 280 active health sector partners were working across the whole of Syria, with 141 of these operating in government of Syria-controlled areas. Despite all this, the health situation continues to deteriorate, with 15.3 million people estimated to be in need of health assistance in 2023. Moving on to primary healthcare indicators in government-controlled areas, primary healthcare service availability has been markedly diminished, with wide variances across governorates contributing to inequitable access of health. Government expenditure on health dropped to less than half in 2020 compared to 2011. Only 8 health staff are available per 10,000 population, which is critically below the benchmark of above 22, according to IASC standards. Finally, due to destruction and limited availability of human resources, medical supplies and equipment, essential drugs, fuel, water, and electricity, only 56% of primary healthcare centers are providing services under full functionality. During conflict, primary healthcare structures mainly rely on international aid, with several bottlenecks recognized across various settings, including underfunding for primary healthcare elements, short-term vision and minimal sustainability of interventions, misalignment of aid allocation and needs on the ground due to inaccuracy of health data, limited coordination, and donor interest. Historically, classical humanitarianism has been serving the objective of providing life-saving aid to conflict-affected populations while adhering to humanitarian principles, including independence, neutrality, humanity, and impartiality. However, modern humanitarianism is linked to shifts in the provision of needs-based aid to serving political agendas, earmarked funding, and dominance of donor priorities, providing funding for short-term health interventions with minimal regards to health system strengthening, population health needs, and sustainable development. This research explores the deterioration of primary health care in government of Syria-controlled areas and the influence of humanitarian aid throughout the conflict by understanding how politicization of humanitarian aid is perceived to affect primary health care. The research follows a qualitative methodology using in-depth semi-structured key informant interviews with 13 health stakeholders, including representatives from donors, UN agencies, NGOs, and the health workers. The data analysis was conducted using thematic analysis with 5 key themes emerging. The first finding describes the challenges and imbalances in primary healthcare funding. Decision-making for primary healthcare funding is donor-led, lacking community inclusion and a needs-based approach. International aid focuses on emergency support, short-term funding, and vertical disease programming, with little flexibility and alignment with emergent health needs. Lack of coordination among health stakeholders and deficient funding transparency are leading to inefficient use of resources, duplication of efforts, restricted ability to track funding, and limited understanding of the impact of interventions. Access to deprived areas, which were most highly affected by the conflict, is restricted, exacerbating health inequalities. Evolving challenges, deficient health data, and conflicting priorities among the various stakeholders and sectors further complicate primary healthcare funding. This finding covers the impact of humanitarian aid on the 6 health system building blocks. Despite the crucial need for health system strengthening, it has been neglected throughout the conflict. Service delivery was impacted by infrastructure damage and lack of resources. Poverty and transportation issues further hinder population access to services, while political and security issues restrict humanitarian access to specific areas, leading to cessation of services and increased burden of disease. The most significant impact of the conflict on the health workforce is the brain drain. Violence and displacement resulted in reduction in the number of health professionals, leaving public health facilities understaffed. Remaining health workers face overwhelming workloads, low pay, and insufficient training, impacting the quality of primary healthcare services. The health information system also suffers from ineffective data collection and analysis, leading to delays in identifying outbreaks and aligning interventions with population needs. Lack of transparency and cooperation among stakeholders hinders effective data sharing and utilization for health planning and response. Health financing faces several issues. Humanitarian aid and government support do not adequately invest in health system strengthening, impacting staff salaries, resource availability, and facility maintenance. Lack of transparency in health financing adds on to resource depletion and undermines effort to addressing gaps in funding priorities. Primary healthcare centers lack essential medical supplies and equipment maintenance due to governmental and international limitations. Electricity, fuel, and water are not available to maintain service delivery. Limited availability of medicines and medical supplies and equipment diminishes population trust in the primary healthcare services, affecting health-seeking behaviors. The Ministry of Health's leadership role has been sidelined, leading to fragmented governance and increased reliance on aid, which caused near collapse of the public health system. Interventions by aid agencies face bureaucratic hurdles, delaying and restricting the capacity to efficiently address health emergencies. Due to restrictions related to supporting the national health system led by the Syrian Ministry of Health, significant international aid was directed towards creating a parallel system, primarily led by the Red Crescent and supported by international and local organizations. The services provided through this system were of higher quality, with better availability of medicines, equipment, and electricity compared to the facilities of the Ministry of Health. Hence, population health-seeking behaviors shifted towards the parallel system, creating dependency on aid and reducing trust in the Ministry of Health system. While this parallel system was essential to maintain some form of service delivery, the risk is that with reduced international funding, the provision of primary health services through aid agencies is expected to decrease, creating a critical gap in population access to health. I will begin this finding on politicization of health aid with a quote by one of the key informants, who said, "The question of whether international aid has been politicized is not a question anymore. It's the extent to which international agencies, the UN, academic centers such as LSE, and donor states are prepared to grapple with it. Our failure to grapple with the politicization of health aid doesn't augur well for the future of primary healthcare. The findings indicate that politicization of aid emerged through various aspects. The aid response is affected by foreign and domestic politics, contributing massively to primary healthcare deterioration. International politics that intend to limit the regime's power and ability to benefit financially, such as sanctions, are only limiting the effectiveness of interventions. The Syrian government exploits humanitarian aid to its benefit, leading to misappropriation, restrictions on interventions, and delays in assistance, hence hindering efficient health responses. Despite the exemption clause on humanitarian aid, the sanctions imposed by Western countries further limit support to primary healthcare, impeding procurements, financial transactions, and access to essential resources. The aid response in Syria is also affected by global politics, such as the war in Ukraine, which led to funding cuts and limited the capacity to maintain provision of essential services. Politicization of aid also restricts international organizations from supporting the Ministry of Health's facilities and hinders interventions in critical areas, leading to deterioration of primary healthcare and delayed recovery efforts. The February 2023 earthquake appears to have important impact on humanitarian health aid in Syria and might be considered a catalyst for political change. The earthquake triggered a spike in humanitarian aid, particularly for medicines and medical supplies. This was also facilitated by reduced restrictions from the Syrian government. The earthquake prompted changes in primary healthcare funding and delivery, with increased investments in resilience building and community empowerment, highlighting the role of civil society actors and communities in the emergency response. The earthquake also prompted changes The earthquake pushed for shifts in politics around humanitarian aid in Syria, leading to temporary lifting of the sanctions, talk on normalization with the Syrian regime, and increased collaboration between the Syrian government and international actors, resulting in more effective aid management. Despite those somewhat positive changes, the future management of humanitarian aid remains unclear, necessitating the development of a clear policy to address population health needs. To conclude, the research demonstrates that politicization of humanitarian health aid in Syria manifested through dominance of donor agendas, absence of a community-inclusive approach, weakening of the health system, earmarked and inflexible funding, a focus on emergency life-saving interventions with neglect to early recovery and development needs, inadequate understanding of local needs and context, and a lack of a holistic approach. Moving forward, it is critical that we explore the impact of humanitarian aid politicization on primary healthcare at the whole of Syria level to enable a holistic and equitable primary healthcare response. Finally, humanitarian aid in Syria should adopt an early recovery and development approach that focuses on health system strengthening and needs-based programming. Thank you.
Thank you, Ayla. And now we move to the second speaker. Just a second. Can we? The presentation is still there. Can I? It will go. This one. Yeah. Just take. Because it's just there. Just stop sharing. Okay. So the second speaker is Dr. Boushra Al-Amin. Boushra Al-Amin, she's a medical doctor specializing in psychiatry. She's currently living in the northwest of Syria, and she has extensive research experience working with Syrian American Medical Association, using qualitative method to explore experiences of women with breast cancer in the northwest of Syria. And her approach, she characterized by compassion. And I would like to say I have the opportunity to work with Boushra Al-Amin on this project, and she's a brilliant person, and her ability to work under very hard circumstances is amazing. So Boushra, are you able? Can you hear us?
Yes, thank you, Dr. Manar. Thank you for this. Appreciate your words. Good afternoon. I'm Dr. Boushra Al-Amin. I'm doctor working in Idlib. I participated with Dr. Alaa Ahmado and Mariam Bakour when we were a student with SAMS to do this research, and I would like to thank my other colleagues who also worked on this. I will share my screen.
Yes, can you share your screen?
Yes. Is it clear?
Yeah. Will you be able? Yeah, that's great.
Yes. Perfect. So I'll start to talk about our study. Our study is about qualitative exploration of the perspective of women with breast cancer in the Northwest Syria, an area of protracted conflict. So I will talk about the oncology in Syria, and oncology diagnosis and management has been severely affected by the conflict, which led to the destruction and fragmentation of Syrian health system. North Syria is particularly affected both before and after conflict due to existing and pre-conflict disparities. Oncology care is adversely affected by shortage of oncologists, diagnostic and treatment, chemotherapy, as well as radiotherapy. Funding for oncology services is neglected as international donor focusing on emergency or humanitarian aid, neglecting expensive, complex, or specialist services. NGOs like SAMS have taken on the responsibility for funding and running complex or specialist services, include oncology care, due to the needs of patients in neglected area. Here we have a provision in the Northwest Syria. There are 4.7 million people, 1.8 million are camp residents, of which a high portion are women. Women face particular challenges to accessing breast cancer care. 42% of all cancers treated in SAMS facilities are breast cancer. Our aim of the study is
can you hear me? Sorry, Bushra?
Yes.
Yes. The slide is not flipping. Can you move to the second slide, the third slide? We're still on the second slide on the screen.
I will stop the share and share it again. Just a minute. Yes. Is it clear now?
Yes, perfect. Yeah, that's great.
Yes. Now, the aim of the study, I said the aim of the study is to explore the perspective of women with breast cancer in Northwest Syria, about the diagnosis and treatment journey and the impact of their diagnosis on them. This complements research in which a retrospective qualitative analysis of 200 patients with breast cancer was conducted. We use the qualitative study design using purposive sampling. Inclusion criteria are listed in here. In the total, we interviewed 22 women who were diagnosed with breast cancer and living in the Northwest Syria. All interviews were conducted in Arabic by 3 female local medical students. I mentioned before. Data were analyzed on in vivo, given the vulnerability of this population. Ethics were obtained from Yale University. The result of the study, we have 3 key findings were categorized into 3 themes: challenging to accessing oncology care in Northwest Syria, interactions with healthcare workers, the role of community and society. The first one is the challenges to accessing oncology care in the Northwest Syria. Participants reported that they preferred having oncology care in the Northwest Syria rather than Turkey, if the treatment is available, as the cost, logistical barriers, travel, and separation from family brought challenges. Within Syria, transportation also was reported to be challenges and difficult, with concerns about security, especially for patients in the North Aleppo. Certain services such as radiotherapy and histopathology were previously unavailable or expensive. Here we have a quote by one of the participants. I will talk about the second one. She said, "I came to Turkey without a companion. Even children who are over 80 years old need to come alone without some to accompany them. This is a real big problem for us." The second one, interaction with healthcare workers. Some doctors had a paternalistic attitude and would tell patients' husband the diagnosis and plan rather than her. In Turkey, the language presented a barrier making navigating health care and understanding what was happening challenging, particularly when away from family. Many noted a lack of information provided in understandable formats about what to expect during treatment, the side effects of the chemotherapy, and how to manage their symptoms. Some women had challenges undergoing an abortion so that they could continue chemotherapy. You have one of them. It seems that I was pregnant, which I didn't know, and they said they cannot do abortion for me. They suggested that I should the abortion by myself. So they said, you go and you do abortion and then come back for treatment. The role of the community and society had both positively and negative impact on patients during their treatment and recovery. Faith and religion was source of the comfort and positively helped with coping. Patient-to-patient peer support appears was noted to be important. A prominent view was the community expected women to be responsible for children and household chores even if they were unwell, and this often had social consequences. So one of the participants said, "I have 3 children. In the beginning, my sister took care of my son who was 7 months old, and the other children were taking care of my parents. Then the community started saying my husband needs to marry again and have another wife to take care of the children. He did this and took the children, so they are far away from me now." So in conclusion, women with breast cancer face many challenges, including bureaucratic, linguistic, financial, logistical, for example, transport and social culture. They face gendered challenges during and after their diagnosis. Improving localization in oncology care in Northwest Syria through training local oncologists, providing diagnostic and treatment, especially radiotherapy, can address some of the practical challenges women face. Healthcare workers have an important role in avoiding patriarchal approach when communicating the diagnosis and treatment and avoiding medical jargon. Strengthening peer support networks may support coping mechanism. Thank you for listening, and I would like to thank all women who participated and the staff from Sam's Oncology Center. And that's all.
Thank you very much, Bushra. Thank you, Bushra. And now we move to our third speaker, Dr. Zaidoun Zabi. I think he's with us here. Yeah, sorry, I was looking in the other direction. So to introduce Dr. Zaidoun, he's a co-lead of research for health systems strengthening and previously worked with Awesome. And he's a distinguished professional in governance, peace building, and civil society development. He's profoundly committed to fostering sustainable and inclusive growth in conflict-affected regions, particularly Syria and in the MENA region, with a rich background as a researcher and facilitator. And you already played pivotal role in establishing several NGOs and civil society initiatives. And his work spans diverse critical areas, including identity, local governance, health governance, networking, and youth engagement, humanitarian support mechanisms. I think many of us know you very well, so...
Thank you.
Thank you very much.
The introduction is longer than the presentation itself. Can you hear me? Not yet, right? Working? I know. Yeah, it's not for you, it's for the people online. Otherwise, I know you don't need I don't need a mic. Technology betrays all this. Maybe send it to someone on Zoom and they can share.
She's still sharing.
If you want, I can do it without PowerPoint. Seriously.
We're trying to sort it. Yeah, you are. Thank you.
Shall I start?
I was trying to sort it.
I can start. Okay. Good morning. Thanks, Benazir, for all the good work today. I know how difficult it is. Okay, let me first explain the reason behind this research. There is no PowerPoint, sorry. It's coming sometime, just wait. The reason behind this research was somehow political. We had that crisis, 6th of Feb, which happens to be my birthday, by the way, but I will never ever celebrate it again. So earthquake happens on the 6th of Feb, and we saw an immediate response to the Syrian civil society and to the health governance institutions, mainly the health directorate. It was astonishing the way they responded. While everyone was responding and we were part of the response itself, we thought, let's document what is happening because everyone is involved. Everyone is busy. No one is writing down what is happening. And we thought that let's do it in a more of a scientific way. Let's not just make journalistic stuff and media. Let's do it as a research to understand what is happening, because what was happening was quite remarkable. In many cases, we saw that the response in Syria was, in a way or another, or even quicker than the response in Turkey. In Syria, you don't have a government, you don't have institutions, and then you have Turkey, one of the strongest countries in the region, and still Syrian civil society was faster in response. So that was a bit bewildering, and then we had to do this research. And then the research, we started to document through interviews 20 days after the crisis. 26 was the 1st of Feb was the first interview. And the last one was April 2023, which means we captured information, we captured data immediately while things were happening. And things were quite hot, like we spoke to people while they were responding. That was for us very critical because we wanted to see what's happening immediately. So we started to interview people. We conducted 13 interviews. we started to interview people from civil defense, health, diaspora, community. Every time we found a new actor, we continued to document. So that was the main reason why we started to do this research. And actually, the research was conducted by a team. I'm representing this team now. Dr. Monzer Khalil, Preeti, Kristen, and our dear colleague Abkarim, who we all pray for him and for his family, who could not join us today. So the first challenge, the question we had in our mind is, what was the response like? And the second question, which is even more important, is who responded? Is it the top-down structure, which is mainly the Salvation government and the Turkish government, depending on which area we are talking about in North and Northwest Syria? And of course, we focused our research only on Northwest Syria. Is it that top-down, governmental, quasi-governmental, or was it the bottom-up civil society health directorate that was like more of a closer to the community? And to do so, we did not follow a framework for two reasons. The most important one is that there is no framework for such thing. We are talking about a compound crisis, civil war, and earthquake at the same time. There is no framework to study governance in such compound crisis. And second, we wanted to see first what the response was at the first time. And then we could, like, for example, compare it to other frameworks. One thing that I can mention, if you go to the 6-block WHO that describes health system, and many researchers use, you will see that many of our findings could not be really figured out through that system. For example, the role of media and what health organizations did with media to keep Syria under the visible to the world, while everyone was busy with Turkey, and there was no government to advocate for Syria. There is no framework that could really capture what was happening between the diaspora and inside Syria, the volunteers, the community leaders. So this is why we actually decided to do like a grounded theory. We went there and we asked people simple questions. What did you see? What did you do? Who did what? When? Etc., etc. So, as I said, we conducted 13 interviews, and then we analyzed them using grounded theory. The main results were as follows. Number one, and could be one of the most important results, is the tacit governance. What we mean by tacit governance is that in Syria, people did not have a document to say, listen, in a crisis, you do 1, 2, 3. This is the policy you should adopt. Do this and then that. Everyone rushed to do a very well orchestrated work without following any manual, any policy, any system. But it was just like, a clock. One of them said, like, we were working like a system, like a clock. Everyone knew what his or her role was. Because of the conflict, people developed the governance they had. They did not know it was a governance system. They wouldn't call it a governance system, but all what they did was exactly the definition of governance. But this was tacit. This was not documented, legal, whatever structure you can think of. The second thing that we noticed is that, contrary to what our assumption was, we had actually some advantages for both systems. The first is for the bottom-up. And here, let me explain what happened exactly there. In Turkey, people were sitting in the streets, waiting for AFAD, for the Red Crescent, to save them, to help them. In Syria, civil society did not wait for anyone, because they were not expecting anyone. They rushed and they moved their trucks. Individuals were talking. Civil defense went immediately to remove rubble and rescue people. that one of the interviewees said that the doctors started to respond 20 minutes after the, like it was 4:40 in the morning when they first started to respond, which means 20 minutes. They went immediately to the right place. Health Directorate established immediately a WhatsApp group, and through that WhatsApp group they did the triage, they did everything you can think of on dealing with the crisis. This was because civil society is light, can move quickly. A state is very slow, cannot respond as quickly as the state had to deploy army. I'm talking about Turkey now. Deploy the army, conduct meetings, etc. No one conducted meetings. Everyone went immediately in Syria. However, speaking of the bottom up as the quick response and the most agile, let us call it this way, response, this was not sustainable. After 1 week, we started to see the top-down institutions, Salvation Government, Turkish government, interim government, to be replacing the response of the civil society. When they wanted a more of a coordinated approach, when we wanted to have a response that goes beyond one sector, when the crisis had to settle, and now we need to think of there's so many people in camps and mosques and schools, then you needed a bigger, more stable institutions. And here came the top-down approach, which means if we want to summarize, the crisis was looked at by two institutions. The first was civil society, quick, agile, light, does not need documentation, does not need a lot of approvals. And the second is the one that is heavy to move, but when it moves, it makes a difference, which is the top-down. Of course, this is why we need more research on the relationship between bottom-up and top-down, especially in conflict areas. Again, before I conclude, I want to just say one thing. There was a bit of like bewildering moment when these people reacted so quickly to the crisis, even proscribed institutions, even HTS, even Salvation Government, they took one step back and they allowed the civil society to lead. So the first thing they asked was, what do you want us to do? So the first thing they did they said, okay, just keep the security and we want some fuel and get out of our way. And this is what exactly was happening. So they left and they let the civil society lead until everything settled down. Of course, then they came back to their old habits of trying to control everything. That's it. Thank you so much. I hope I didn't take much of your time. Thank you.
Perfect time management. Yeah. Perfect. Thank you, everyone. So now we will move to the questions and answers. So just to see like if there are some questions in the chat. I don't know, it's not, no way we can get it to share. Yeah, it's fine. So. No question. Okay. So do we have any question from the participant here? Yes, Dr. Munzer. Start. Dr. Munzer.
Thank you. This is Munzer Khalil. So my question for Ayla. In your recommendation, you mentioned the need for more collaboration between donors and the Syrian government to achieve like more community-based governance and like more localization agenda. So my question, do you think that the collaboration should be at this level between the donors and the Ministry of Health, or maybe at more local level? for example, with health directorates and local NGOs, because we know that one of the issues in Syria is the involvement of the Syrian regime in war crimes, and for this reason donors probably avoided to deal directly with the Syrian government, and this caused a parallel health system in Syria. So I'm not sure actually if more collaboration with the central government in Syria will improve the health situation and cause more community-based governance or more sustainability actually for health services in Syria. Thank you.
You want to answer?
Yeah, sure. Thank you so much. So I think there's some sort of misunderstanding. The recommendation is not to directly work with the Syrian regime. The recommendation is rather to support the health facilities that are governed through the Ministry of Health, just because the health system is structured that way in Syria, and specifically in government-controlled areas where the Ministry of Health is still the governing body. Without support to these health facilities, we are risking that primary healthcare is only delivered through the parallel system, which is currently run by the Red Crescent and local and international organizations. And then once international funding stops, there are no more public health services for the population. Thank you.
Thank you. Lujain?
Thank you. My question to Mr. Zaidoun. Thank you very much for the interesting insight. My question would be, in your opinion, whether it's a top-down or a bottom-up approach. Just understanding how it happened and how remarkable it was because of the resilience of the society and their ability to just respond because there is an ongoing crisis and they are ready to respond basically. But in terms of the outcome, comparing between the northwestern Syria and Turkey, what difference would that make if the civil society were able to respond immediately, whereas in Turkey, as you mentioned, they had to go through the bureaucracy and approvals and meetings and stuff? What did that make as an impact on the society, on the outcome of responding to the people? Thank you.
Thank you. Well, if I want to give a recommendation now after all what we have seen, I would say in a crisis, the first thing a government should do is to let society respond as quickly as possible. No matter what we do, the state will be slower than civil society and the community. It is, structured like this. So if I would give a recommendation to any government in a crisis, then yes, please let civil society act. Civil society will be better responding to the crisis in the first couple of hours, if not couple of days. Now, what difference did it make? Actually, if we look at Turkey, for example, first, because it had to be it was very slow, many people lost their lives. For example, using the dogs, it took time before they allowed. Before they deployed the army, it took around 12 hours before they deployed the army, or even 24 hours. And before that, it was chaos. There was no responding agency. People used to call, and it was one of our colleagues, very, very dear colleagues, lost his father, mother, and brother. And he was telling me, it was just if you knew the official in the municipality, then this person would send you a truck, for example, to help rescue your family. If you didn't know them, khalas, you're out. And again, I'm sorry to say that. if you are a Syrian in Turkey, then it is less likely to convince officials to come to support you in rescuing people. And many people do not know that. Many of the victims actually were in Antakya were Syrians. And either they got the Turkish nationality or not, they are still seen Syrians. And people lost their lives because of that. On the contrary, in Syria, everyone was rushing to help everyone. We heard some bad stories about certain areas, but in most of the cases, in the vast majority of cases, no one looked at anything, just rushed to save people. So yeah. I'm not the moderator, she is. She decides.
Just a bit of a follow-up. Thank you very much. I know this might sound really weird, but like in terms of numbers, do we have any comparison in terms of numbers, like of people who were rescued? Because from what you're saying, I'm understanding the difference might be in the culture, the cohesion of the society, and that is really important. You cannot, as a government, give permission to civil society when there's no civil society, or the structure of the community is not even coherent. It's not, there is no network. So I don't know if I'm making sense, but the approach is different because the culture is different.
It might be the culture, but I would say it is more of the experience of the war. 10 years in the war, Syrians have developed experience in dealing with a bomb, which is somehow similar to an earthquake. So I don't know if that is a culture or not, but at least the culture now in Syria is that don't wait for anyone to rescue you, because there is no one who will be ready to come to rescue you. Rescue yourself, rescue your neighbor, rescue your friend. That is the only way it works. And that what happened. Now, in terms of numbers, let me be very clear here and honest. We are quite subjective to say that the response here was quicker than there, because this requires a lot of data. For us, this what was told to us by the interviewees, and this was our own observation. But also we need to take into consideration is that the size of the earthquake, the magnitude of the earthquake in Turkey was bigger than the one in Syria, which also made a difference. And there is one last thing that I have to mention, is that if you are in a tent, then you are less likely to suffer from an earthquake. Whereas if you are in a multi-story building, then that is the disaster. So to be very, very honest with that.
Thank you to everyone, to all the speakers. All of the presentations were really interesting. My question's for Ayla. I actually did really similar research, but looking at opinions on primary healthcare in Northwest Syria, so in non-government controlled areas. And our findings were almost exactly the same as yours. So I just wanted to get your opinion on why you think the Ministry of Health has not really had any impact on health governance in the region. And it may be, as Dr. Khalil was saying, that international organizations are not willing to work with the Ministry of Health. But I just wanted to see if you had any idea about why governance is still being so poor.
Yeah, thank you so much. And I think I started with the presentation saying that the findings are actually cross-cutting. The reason why the Ministry of Health hasn't had the governance and leadership role is not only because international organizations are not collaborating with it and supporting it, but it's also because of the way the health system is built in Syria. So basically, as I said, the health financing by the government has been reduced to less than half. There's minimal support to the Ministry of Health. They were trying to move to a decentralized approach, but then you get all the bureaucracy that's been built for generations and generations, so you cannot really overcome that. And then there's no system in place, really. So the role of the Ministry of Health has failed. Thank you.
We will take 2 questions.
Just a quick question. It's actually a follow-up for my friend's question there. Just if we can compare between the civil society-based intervention with the system-based or international organization-based interventions, it's very hard to compare because there is a big difference in resources. But we can say that the rapid response of the civil society, based on the culture maybe, have you looked in your recommendation how to leverage that? How
leverage what exactly?
Leverage the rapid response of the civil-based society, or the civil society interventions, because it's rapid, it's there, and we can actually use it. But what is the mechanism to use that and put it into action and integrate it with the system-based interventions in terms of emergency?
Should I respond?
Yes, please.
Well, yes, of course. The main thing here is every country has their plans for emergencies. You hardly find this in their documentation on how to deal with civil society and such and such. They speak of using the resources of the state. They say everybody is involved, no one should be excluded, but there is no specific focus on the role of civil society. And yes, I of course, we had this as a recommendation that civil society has to be given the space and given this culture. And by the way, also to comment on this, if you look at the other side, which is in government-held areas, we had a similar approach. Civil society in government-held areas, knowing what we know about civil society in government-held areas, was quicker, faster, better. Unfortunately, the Syrian government felt like threatened. And after 24 hours, they stopped them. They said, you are not allowed to interfere anymore. So while the government was not rescuing people, it also stopped this civil society from rescuing the people. And this gives you what could be done if the government, not the Syrian government, because I don't think they will do it ever, but I'm talking about in the thing in general. If governments understand how important it is to leave it for civil society in the first, to be the first responders, then I think the response would be much, much, much better. And as again, as I said, even in government-held areas, with the civil society that is far less experienced than the civil society in Northwest because of many, many, many reasons, including donor policies, still the response in Latakia, in Aleppo, was really, really good, But the government did not allow them because of things that I don't want to mention now.
Can I follow up, to say, do you think on long term this will be the same case, or how it? Because I think your study was more focused on the immediate aftermath of the earthquake, but how it will be the comparison between top down and.
I mean, let me say personally, I still think that you will need both. You cannot let the country to be run by civil society. That's not possible. Civil society is small, agile, knows how to jump from place to place, to provide direct assistance, but run the crisis, this is dangerous. Civil society cannot replace the state. This is why we said, good, leave the civil society, amazing job, but at one point of time, top-down systems have to be there, have to be led there, actually, I mean.
Okay, thank you, Zaidoun. Thank you, Ayla, for your presentations. My question or comments on Ayla presentation, I didn't notice that or see the impact of Syrian government and Ministry of Defense influence in health system and the direction of Ministry of Defense to the health services in Syria, especially in area controlled by regime. And also maybe if we looking to the reflection of Syrian government on organizations' request in South Syria during 2018 when the regime take control in the area with Russian forces, and they not allow or not accept work of international and national organization there, and put many of distractions and to not allow them to work there. This very negatively impact and reflect on the health system, and especially primary health services in South Syria as example. And maybe we can speak also about the destruction of infrastructure done by the Syrian government in all Syria and the countryside of Damascus and north of Homs. Thank you.
Yeah, thank you. So I think the role of the Ministry of Defense did not really emerge in the research, and I think partially because this was limited to a master's dissertation, so it's not as big as it can be. The second issue related to access to, for example, southern parts of Syria and areas that were most impacted by the war, this was mentioned. So due to political decisions and also security situations, a lot of that access was deprived to humanitarian organizations to go and support these areas, therefore leading to cessation of services in a lot of these areas. Thank you.
Thank you. So we'll take another two questions, and there is a man here there upstairs. Yeah, both.
So this was just to Dr. Bushra. I mean, if I could just ask, in terms of access to, so because it's been so difficult for the patients to go to Turkey and get their treatment, is there any kind of initiatives to get specialized treatments for like cancer, like radiotherapy in Northwest Syria?
And can you please ask also the, I think, last question? Yeah, please. Other two. I think we're running out of time. I think only two, because I think he raised his hand first. Please, if you can. Sorry, though, like we should have priority.
Can I ask now, or yeah? My question is to Dr. Zaidoun. I mean, during the first few days of the earthquake, was there a concern in your research? Did you find any concern in safety and security? I mean, crimes, looting, something like that, to see the role of the top-down government, because this was a big concern in Turkey. Yeah, thank you.
Thank you. Sorry? Yeah,
there is Bushra, right? There's a question for Bushra.
Yeah, oh, actually, sorry. I don't know if she can hear us.
Bushra, can you hear us? عم تسمعينا شيء بشرى؟
بشرى؟ بشرى عم تسمعينا؟
Yeah, I think Bushra can hear us. Let me change the speaker. Bushra, can you say something?
Someone is calling, I think, from.
Oh, she can't hear us? No?
She can? If yes, then let her speak, let her answer.
We can't hear her.
Okay.
Okay, can we answer the first question first until we figure out?
My question, right?
Yeah.
Okay. Surprisingly, no, there was not much issues related to security, looting, harassment. On the contrary, it was reported that security was quite good in the first week. Later on, after the first week, something started to happen, yes. But in the first week, no. At least that was did not reach a magnitude to be worrying to the society. No one said that there was an issue of looting. Right, Munzer? Am I? There was not a single interview who said there was an issue with security. Actually, they said, on the contrary, that security was very good.
Thank you.
Thank you.
Can you please repeat your question again to Bushra, please? Can you say? Yeah. Okay. Bushra, can you hear us now?
Yes.
عم تسمعينا هلا؟
Yes.
بشرى سمعتينا شيء؟
She said yes. Yes.
اوكي اوكي سمعتي السؤال اللي انسأل؟
Yes, it's about the يعني كانت تسأل إنه هي عن الخدمات المقدمة بعنا مو إنه على الكيموثيرابي like
yes
إذا
بدك تحكي بالعربي أنا فيني ترجم.
تمام. هلا في الشمال I can do both but I will talk in Arabic.
Yes. As you want.
Yes. هلا في عنا بالشمال شمال غرب سوريا هو الصراحة في مركزين اللي هن تابعين للسامز بالأساس في إدلب في مشفى المحافظة وفي بالباب كمان تابع أيضا للسامز. هدول أكثر هدول المركزين اللي متوافرين في شمال غرب سوريا إنه عم يتم العلاج بتوفر مرات الجرعات الكيموثيرابي إنه مجانيا ومرات لا مرات بكون إنه على المريض هو إنه رح يجيبها. الراديوثيرابي على كان في إنه مشروع جديد هي منظمة الأمين على أساس يبدأ علاج إنه بالراديوثيرابي بشمال سوريا بس ما في لحد الآن عنه إنه في المريضات إنه تواصلوا أو حدا إنه كان من المريضات اللي نحن عملنا معهم مقابلات إنه تعالجوا فيه. ما زال لسه الأمر بروح على تركيا. بوقت الزلزال كان في كتير صعوبات وواجهت كمان المرضى اللي عملنا معهم مقابلات لأنه ما عاد يحسنوا يروحوا لهنيك يتابعوا العلاج بس لسه في ضعف في العلاج توفر العلاج للمرضى ووصولا له.
Okay. Thank you,
إذا هذا كان السؤال يعني.
Yeah, thank you, Bushra. Can I just translate before I forget? So in the Northwest, she mentioned there are two centers run by SAMS in Idlib city, Al-Muhafaza Hospital and Al-Bab. And actually there is another one in Jarablus. They provide only chemotherapy. And however, I think with radiotherapy, it's only like it has been now provided through Al-Amin. There is a project to start providing it. However, when we conducted the interviews, none of the patients they have been treated so far, and they have this is why like they need to cross like to Turkey for radiotherapy. And to be honest, to top on what Bushra mentioned, as well for chemotherapy, because sometimes because of the supply chain, because of the like chemotherapy, so they do a couple of sessions in Mashfa al-Muhafaza, and then they need to go to Turkey to continue with their sessions. So yeah. And another point she mentioned is during the earthquake, the access to health services has been reduced, and especially like the transportation to Turkey has been like interrupted. Yeah. Thank you. Thank you, everyone. Thank you, everyone, for all questions, for participants. Thank you for presenters. Thank you, Bushra, for joining us. Yeah. Thank you, everyone, and Ayla and Dr. And now for lunch break. Yeah, and yeah, I hope those online as well, you'll have lunch to break as well now. Do you have this from Ramadan? Do you have any? No. I realized. I think you were with us all my group. I'm just like, I don't really.
All right, test. Do I speak here or is it he'll unmute? Okay. I'm on the mic? Okay. All right. Can you guys hear me? Hello, everyone. Thanks for joining. I want to thank all the presenters today. My name is Malik Muqaddim. I'm HPSS Program Manager with Mahad. Mahad has been operating in Northwest Syria and Northeast Syria since the beginning of the conflict, and most recently in Ukraine, Gaza, and Yemen. I do want to say I'm grateful for the presenters today to dedicate some time specifically to MHPSS, because during my time in Gaziantep working for Northwest Syria, we see that MHPSS is sometimes a luxury. That's the general notion of what people say. But as the opening remarks were mentioned, there's actually a suicide phenomenon. Very often do we hear that people are taking their lives, and I'm grateful for the advocacy from the presenters today and hear about their work. I'll leave it to the speakers. We'll have four presenters throughout this session, starting with Dr. Jibril Kanaan. Jibril Kanaan is a licensed general practitioner, medical doctor. He completed his medical degree at Al-Ba'ath University in Syria and received his clinical training at Damascus University Hospital at Papagergiou Hospital in Greece. He obtained his master's degree in public health from the Faculty of Medicine in Porto, and he's an integrated researcher in the Policy and Health Laboratory of the ITR in the Public Health Institution at the University of Porto. His research interest focuses on public mental health, vulnerable populations, and improving the public health of minorities and migrants. I'll leave it to you. Thank you so much.
Hello everyone. I'm happy to share with you this project that was on post-traumatic stress disorders among Syrian children and adolescents who exposed to conflict. This study was a systematic review and meta-analysis of the prevalence and determinants, and was done in collaboration with Porto University and supervised by Professor Teresa Liao. So 13 years of an ongoing armed conflict in Syria has forced more than 13 million Syrians to flee their home, and there is estimate more than 12 million of Syrians needed health assistance. This conflict has severe impact not only on the physical well-being, but also on the mental and the social well-being of Syrian, and the data can show how really the well-being has been affected. One of the most underestimated consequences of conflicts and war are mental health consequences that can go underestimated and underseen. Exposure to traumatic event can result in serious mental, behavioral, and emotional disorders in children and adolescents in particular, such as anxiety, depression, and post-traumatic stress disorders. So post-traumatic stress disorders is psychiatric disorders that can happen in people who witness traumatic life events and can characterize in intrusive thoughts, flashbacks, nightmares, and avoidance behavior. PTSD may cause disability and affect social and educational performance in children. So the main objective of this study was to give a comprehensive systematic review and meta-analysis to estimate the prevalence, the real prevalence of PTSD among Syrian children and adolescents who were exposed to the Syrian conflict, exploring its associated risk and protective factors for a better approach to mental health interventions and eventually public health policies. As for the methods, the study followed the PRISMA guidelines and used the published data from the electronic databases of PubMed, Scopus, PsycInfo, and also the Gray literature and NGO literature using mesh terms. And the extracted data included the sample characteristics such as the age, gender, and sample size, as well in context settings, the country of living, the visa status, and duration of stays of participants, as well for the prevalence of PTSD, the assessment methods used, type of trauma events, and risk and protective factors. The meta-analysis of the PTSD was done using Stata software, and the risk of bias of study and the study qualities were assessed using the US National Health Institute method. Here we can see a diagram of the identification and the screening process of the data, and the screening against the inclusion and inclusion criteria. So the result of 239 results ended up to include 26 studies that, with a total of participants, 11,400 Syrian children and adolescents. Most of those children lived in Turkey and the neighboring refugee countries such as Lebanon and Jordan. Few studies was conducted in European countries, one in the US, and unfortunately only 2 of the studies were conducted in Syria, Damascus, and none of them in the northwest of Syria. As the range of the PTSD, the range was between 6.3 to 65.3 of Syrians under age of 18 were affected by PTSD. Of course, this was a big range, so a pooled meta-analysis was performed, and it gave an estimate of 36% of Syrian children were affected by PTSD, or almost 1 out of 3 children that lived inside Syria and lived the war were affected by PTSD. Here we can see a figure of the meta-analysis that was performed for the pooled data, and also secondary to meta-analysis based on the type of assessment of the studies. As for the identified determinants, as for the risk factors, in the first position was a loss of family members, so to have very associated risk for having PTSD as well, witnessing violence, displacement, economy and social deprivation, social withdrawal, and low maternal attachment. On the other hand, social trust and social support showed to have protective influence against having PTSD. There was no significant association or mixed results for age, gender, and other socioeconomic factors. So, for a discussion, PTSD, if we look for the literacy and the published publication, the Syrian have shown to have a higher PTSD prevalence than their peer review studies, and the only similar or comparable result was found in Palestine. This was in 2005. Unfortunately, the struggle going till our day for the Palestinian children. And this very high PTSD prevalence possibly explained by extreme traumatic experiences, conflict-related trauma, and extreme deprivation and displacement. So some of the limitation and literature gaps, few of the study assessed the determinants and risk and protective factors. Only cross-sectional study was performed. So there is a need of cohort study for a better understanding on the long term on the progression of this PTSD among those children. And as for the samplings, most of those studies use sampling from schools. These can underestimate the stateless or marginated high-risk groups. and a few studies were conducted inside Syria, and none of it was conducted in the northwest. Mental health comorbidities were also not explored, and there was no clear statistics and data for legal work and sexual and domestic violence against children. So as a conclusion, PTSD is highly prevalent among Syrian children and adolescents exposed to the conflict, with a higher estimate than those found in the peer studies. This knowledge emphasizes the urgent mental health needs of conflict-affected children and adolescents in particular. So what can be done and what needs to be done? I summed it up in 5 major points. First is to urge policymakers and stakeholders at the national and international level to develop a plan and implement it for children mental health in Syria and also in the neighboring refugee hosting country. 2, to increase the financial resources, allocating more funding for mental health programs, hiring more mental health professionals, and expanding access to affordable mental health care. Today there is a lack and a severe lack of the psychiatrists and also clinical psychologists in Syria. 3, coordinating and supporting community-based intervention. This is also what mentioned extensively Dr. Zaidoun. This can be community-based intervention can be very effective and prompt in emergency settings, and this could involve training community health workers and volunteers and establishing safe spaces for children to receive psychosocial support. So strengthening training pre and in-service context, enhancing education and training of healthcare professionals, and lastly, to integrate mental health psychosocial support into primary caregivers' roles and also educational environment for children. This can play a very essential role to early identify the the mental health disorders and to deal with it, as well to address mental health stigma and literacy in these settings. So, thank you very much for your attention. I would like to end this with a quote says, "Every loser in war is a child," and a photograph I took in Syria represents beauty and peace over war. Thank you very much.
Thank you, Dr. Kanan, for keeping time. I think our next presenter will be Mr. Mohamed Mukrish, who is going to be online. Dr. Mohamed is a 5th-year medical student at the University of Health Sciences. He's a dedicated medical student, passionate researcher, and proficient data analyst. With a keen interest in advancing healthcare through innovative research methodologies with a focus on improving patient outcomes and healthcare systems. Mr. Mohamed, are you with us right now?
Yes, I am. Okay. I hope my voice is clear.
I think we can raise the volume. Yeah. And maybe I'll give you a 2 minutes heads up before the time ends. Is that fine?
Yeah, right.
Sounds good.
Let's get started. So, good afternoon, everyone. Thanks for the introduction. I'm glad to be here at this great conference to present our study that conducted in Syria. Today, I want to take you on a journey through the mental health landscape of Northwest Syria. This study was conducted by both graduated and undergraduate medical students from both Turkey and Syria. So our collaborators from Idlib University, Free Aleppo University, and the International University of Science and Renaissance, they played a crucial role in collecting data during the aftermath of the earthquake. Their dedication and hard work, despite the challenging circumstances, have provided invaluable insights into the mental health challenges faced by region's residents. So I'll start with a quick introduction. As already discussed at the beginning of the conference, this region has been severely impacted by the ongoing Syrian conflict, which began in 2011 and has led to widespread destruction, displacement, and trauma. Additionally, in 2023, a powerful earthquake struck the area, exacerbating the already dire situation. These events have left deep psychological scars on the inhabitants, who have endured not only physical and economic hardships, but also significant mental health challenges. So our primary goal was to understand the perceptions, knowledge, and stigma surrounding mental health among the people of Northwest Syria. Firstly, the ethics approval was taken from Idlib University. We conducted a cross-sectional online survey using Hubu and tried to reach a broad audience. The survey included internationally recognized skills like the mental health knowledge schedule, the community attitudes toward mental illness, and the reported and intended behavior scale. The survey was administered around the time of the earthquake. Like I said at the beginning of the presentation, our collaborators from these mentioned universities were instrumental in this effort. So we had a total of 320 participants with a fairly balanced gender distribution, with a slight male predominance. Most respondents were living in their original homes, but a significant portion resided in refugee camps, unfortunately. The majority of our participants were young adults, aged between 18 and 29. So the study provides a crucial perspective on how the younger generation is coping with these challenges. One striking finding was the lack of awareness about mental health issues. Over 2/3 of participants have never seen mental health-related advertisements. Furthermore, there was a considerable underestimation of the prevalence of these issues, with many believing that only 1 in 50 or even 1 in 100 people are affected, while global studies show that 1 in 8 people worldwide are affected. Also, interestingly, males showed significantly better knowledge about mental health than females. So, as a conclusion, our study highlights a significant gap in knowledge about mental health in Northwest Syria. Many people underestimated the prevalence of mental health disorders, this underscoring the urgent need for targeted awareness campaigns, especially among females. This is a critical step toward breaking down the stigma and encouraging more people to seek help. To address these challenges, we recommend implementing targeted awareness campaigns and incorporating mental health education into school and community programs. Additionally, offering culturally sensitive mental health services can make a substantial difference in improving the overall mental well-being of the population. So I would like to extend my heartfelt thanks to all the participants who contributed to this study, and special thanks also go to our collaborators for their invaluable supports. And thank you for listening.
Shukran, thank you, Mr. Mohammed. And I think our next presenter as well will be online. We have Miss Diana Reyes, I'm not sure if I'm pronouncing that right. Miss Diana is a PhD candidate at Johns Hopkins University with the Bloomberg School of Public Health. She also holds a Master of Health Science degree from Johns Hopkins, specializing in global mental health and humanitarian assistance. Diana also chairs the Syria Public Health Network, where she leads research and policy dissemination on public health trends resulting from the Syrian crisis. She has previous affiliations with organizations such as the Tahrir Institute for Middle East Policy, the World Health Organization, the Syrian American Medical Society, and the Lancet Commission on Syria, concentrating on public health trends and refugee issues in the Middle East region. Currently, she consults for UNICEF's global mental health team to support the scale-up of advocacy and policies to improve child and adolescent mental health. Ms. Diana, please, the floor is yours.
Thank you very much to the conference organizers for having me today, and to my fellow panelists for setting the scene regarding the importance of mental health inside Syria. So I'm here to give you context from a health system perspective regarding a study we conducted at Johns Hopkins and University of California, Berkeley, in collaboration with the Syrian American Medical Society and Assistance Coordination Unit on the impacts of attacks on healthcare. And it's a qualitative study interviewing health workers on these impacts. And I hope this will paint a picture of what happens when hospitals and medical facilities are destroyed and there's an absence of care, how this affects both patient populations as well as health workers. So a little bit on the study background. This is part of a larger study, multi-methods, that use both quantitative data from SAMs regarding their health services, as well as qualitative interviews. And the study that I'm sharing with you today is the qualitative portion of this project. And the aim was broad, so you'll see where the mental health component comes out throughout the interviews, but the aim was really to look broadly at the health system, how complex and compounding impacts of violence affect the accessibility and availability of care, how it affects health outcomes in the community, as well as the long-term stability of health resources. And I'm just realizing my camera is off, but I'll do my best to turn it on eventually. Here we go. Okay, looks like I can't share it, but I see you all, which is fine. So in terms of the health system building blocks, this is the framework that we used to analyze the study, and we used these standard building blocks from the WHO, looking at service delivery, health workforce, access to essential medicines, financing, leadership, and governance. And we actually replaced the building block on health information systems, which are important, obviously, in any health system context, but especially in this setting, looking at security and protection as, one of the key blocks to sustaining a health system. So when this is violated, and that's what we show in this study, you can see how it has implications for health outcomes. Very briefly on methods, the interviews were done by Arabic-speaking interviewers, including myself. We obtained informed consent and ethical approval from the Idlib Health Directorate and interviewed healthcare workers that were part of the SAMS and ACU community. And we used snowball sampling in order to reach other health workers. We're quite proud of the representation of our study participants. We had about 40 total participating. These are all health workers that have experienced attacks on healthcare and have lived experience. We did our very best to have a good representation of female health workers because studies in the past have not had this. So we reached about 32% of the population being female health workers. And we also tried to reach a diverse cadre of health workers. So you can see here that not only physicians are represented here, but also nurses and technicians, administrators, first responders, and even medical students. So it was great to hear from the fellow panelists about medical students in Northwest Syria who are, who unfortunately had to experience this attacks on healthcare during their training, but have a lot of insights to share. And here's a brief demonstration of where the study's participants were located and where they're represented. And I'll walk you through the study themes very broadly and then touch on some of the mental health aspects in particular. So there were severe constraints on health service delivery as a result of attacks, resulting in irreparable damage to health facilities. So one quote here from an administrator is that if a destroyed hospital was providing services to an area of 500,000 people, then that 500,000 people would be without health care for a month, and they would have to go to other areas and their diagnosis might be delayed. In addition to irreparable damage, there was also ripple effects on nearby facilities. So one of our participants, a nurse, said that if a hospital was bombed, then all other hospitals were bombed. So that were nearby. So hospital receiving patients from across different parts of Northwest Syria, and this resulted in an intense workload on nurses. So a lot of the participants I spoke to started to mention how much work and stress they were under as health workers and the responsibility of serving the needs of these vast communities. The other thing, and this is pertaining to mental health in particular, is the loss of specialized services. So as you know, in Syria, there was a lack of psychiatric care to begin with, pre-conflict, but this was exacerbated when attacks on hospitals took place, and there was a loss of healthcare workers in terms of displacement, or they were injured or unfortunately died, and so they weren't able to, so health services became even more desperate in these contexts. This was highlighted also with cancer patients. So now they have two options, either to head towards Damascus or towards Turkey, which is what one of our participants said. And you can imagine the kind of, let's say, distress this causes patients of these individuals. So specific patients, but then family members of these individuals who are trying to support them and accessing the care that they need. This is where we started to see a lot of the themes regarding mental health needs of health workers, which is why we actually produced a separate paper just focusing on healthcare worker mental health. There was a lot of challenges in terms of their retention as health workers and their morale. So the first thing, in terms of physical constraints, is displacement, multiple displacement of health workers, and unemployment. So one of the quotes here regarding the displacement of health workers is, physical retention is difficult as the hospital is rebuilding and health workers need to find work in the meantime and then come back. The other component is a lack of sustained skills and training for these health workers. And something else that came up was feelings of resistance and solidarity, which was a positive thing that allowed health workers to carry on. So one of the physicians we spoke to said that the feeling that makes him feel most at ease is that there's a wounded person in need of rescue. He'll die if I don't do my job. The possibility is 100%, whereas the probability of my death and targeting is 5%. So the feeling of rescue always prevails over me. Very powerful way to express, the sacrifice that this health worker is making in terms of supporting patients in their community. So I'll skip through a little bit more of the health system components since they're less related to mental health, but just wanted to highlight these in terms of what else our study found regarding loss of essential medicines and infrastructure, weakened health governance, uncertainties in health financing. So when funding streams were interrupted, the inability to sustain the health system, as well as compromised security and protection, not only of health workers, but patients as well. This was about a physician spoke to us about the deconfliction mechanism that was put into place by the UN. This was happening around the same time we did the interviews. So when this physician gave this quote, he was saying that we did everything we had to do, and we told them that these locations were medical centers, but we were regarded as enemies, and then we were attacked. No one stopped these attacks. So this fed into the hopelessness of the situation and the lack of solutions for the protection of health workers. And wanted to touch base about the impacts on community health. So forced displacement of communities made towns become empty. So also when hospitals were targeted, people left because there was no health care. Then it also resulted in avoidant health-seeking behaviors. So patients would say to themselves, I'd rather be sick than to go to the hospital and risk attack. And there was also a perceived increase in disease prevalence, not only infectious diseases, but also mental health conditions. So health workers told us they'd seen more mental health needs emerge because of attacks, including anxiety, post-traumatic stress, alongside other symptoms. And just to briefly feature some of the other work we've published on this topic. So we did a separate paper just on the psychological impacts on health workers. And this quote is probably the most powerful from that study, which was from a doctor who said that the psychological wounds are more difficult than the physical injuries. And whether he was referring to himself or patients, I'm not entirely sure, but I think generally just capturing that the psychological impacts were lasting as a result of attacks. So one of the key themes was psychological harms. And this physician is expressing that he felt a lot of anxiety every time that he was targeted, or even when he was remembering the targeted attack. And when he was speaking to me, saying that his hands were shaking, feeling stressed. So very, very sad and very demoralizing for physicians, for health workers who are trying to help patients in their communities and felt hopeless about this situation. I think the other thing is that when people feel this way as health workers, then they have a lack of incentive to come back, or they feel like they're going against their will to serve the needs of the community because of their fear of attacks. We talked about the impact of net attacks on healthcare on mental health, and some of the participants really drive this point forward, that these were some of the hardest moments for them. And as a patient, you cannot leave the hospital, but you could hear warplanes around you, and even the ambulance couldn't reach you to take injured individuals to the hospital. So very difficult moments for health workers and patients.
And I'd like to invite you to wrap up. There's a minute left.
Okay, sounds good. Thank you. So on the coping mechanisms that we saw among health workers is really a solidarity among participants with one another. So being able to relate to other health workers who go through the same thing. There was a lot of dark humor, which, it's unfortunate, but if it works for individuals in these circumstances as a coping mechanism in the short term, it's something that we noted and that, people rely on to support themselves. Also, it's not mentioned here, but faith was a huge coping mechanism for these individuals, as well as bonding with others. So very quickly, in terms of the recommendations, there is an urgent need for strategies to prevent, first and foremost, attacks, to protect health workers and make sure health systems are intact. And then NGOs in particular who support health workers should pay more attention to these ethical dilemmas health workers are facing, and call on donors and apply for funding for psychosocial support of health workers in Syria. But first and foremost is the prevention of attacks on healthcare, which have long-term impacts not only on health workers, but the health system as a whole. So some acknowledgements here, and then if you'd like to take a look at the studies, we have the preprint on the left and then the published study on the right. You can use the QR codes. Looking forward to your questions. Thank you.
Thank you, Diana. And I think this brings us to our last presenter for this session. We have Ms. Thuraya Zre. Thuraya Zre holds a Master's in Science in Medical Anthropology from the University of Oxford and has been working in the field of public health research in Lebanon since 2015 with a focus on health in conflict as well as mental health. She has worked with academic, governmental, and non-governmental institutions in Lebanon and the Arab region. Since 2020, Ms. Zre has been the Lebanon research lead for the GOAL project, a multi-stakeholder project under the London School of Hygiene and Tropical Medicine, and in partnership with the National Mental Health Program at the Ministry of Public Health, the University of St. Joseph in Lebanon, War Child Holland, and other local and international actors. She is also co-founder of the first mental health service user association in Lebanon. I do believe, there you are. Yeah, here, go for it. Okay. Batiki daitain, okay?
Okay. Okay, thank you so much. Thank you everyone here. I'm really grateful to be here today and to have listened to all of the presentations before. We talked a lot about humanitarian system today in multiple presentations, and we also touched upon the importance of localizing aid. So today I'm going to present to you a case study in this pursuit. So this study was part of the GOAL project that was just mentioned. It's a multi-stakeholder, multinational project, and it takes place in Lebanon, where there's 1 million plus Syrian refugees, and the estimates are closer to 2 million. So the background and the aim of this study was first of all, the humanitarian sector, we touched upon it already, has been criticized previously for being bureaucratic, hierarchical, and having a lack of accountability to affected populations. And the discussions on power dynamics have been happening more frequently as part of the push to localize and decolonize humanitarian aid. So this study examines how power dynamics influence the decision-making and participation inside the MHPSS task force in Lebanon, which is a humanitarian coordination group focused on mental health and psychosocial support, MHPSS, in Lebanon. quickly about the task force. It's the only nationally led humanitarian coordination mechanism for the MHPSS humanitarian response in Lebanon. It's chaired by the Ministry of Health National Mental Health Program in Lebanon, as well as being co-chaired by UNICEF and WHO. It has around 60 member organizations from local to international NGOs, civil society, UN agency, and other ministries. And its aim is to ensure an effective, coordinated, and focused interagency response to the MHPSS needs of persons living in Lebanon, with a special focus on vulnerable Lebanese population and Syrian refugees. As a function, they meet regularly to coordinate activities, develop guidelines, and participate in the development and implementation of an annual action plan, which guides the work of the task force and the member organizations throughout the year. When we wanted to look at power inside this coordination group, we used the following frameworks. We used Gaventa's Power Cube, which is useful in looking at different levels, spaces, and forms of power. And we also used Arnstein's ladder of participation, if you're familiar with it. It's a pretty classical framework for participation. And we looked at the different levels, which I will go through in the findings. So we had qualitative methods. We did data collection between February and November 2021. We also reviewed background documents for the task force. We interviewed 34 participants, mostly female, which reflects the aid worker gender divide in Lebanon, and I think across that, in English and Arabic. For data analysis, we coded and analyzed the data collaboratively within our team, which was part of Goal's bigger commitment to co-production. So if you're interested about using these methods later as well for decolonizing research or trying to localize research, those are detailed in another paper. And of course, we reflected on our own positionality and relations as researchers. So the key findings, first, UN agencies and international NGOs are perceived almost across the board to have more influence in this coordination group as part of their power within the humanitarian sector. So because they hold funding power in the humanitarian sector, and because they are perceived as more credible, according to the members that we interviewed, they had more they had more ability to make decisions and have a voice in the task force. Also, they were described as having smaller meetings that exclude other stakeholders, and a lot of task force members talked about there being a core group, which is smaller, that is responsible for decision making, even though the leadership themselves clarified that there was no formalized core group, but it came up many times and in the feedback sessions we did. And when participants obviously talked about the power these agencies and organizations had, they did situate it inside the hierarchies present in the humanitarian system. In terms of the power dynamics that influence decision-making and voice in the task force meetings, first, seniority. So inside the meetings, senior members would take up more space because they were seen as more experienced or they had more technical knowledge, whereas the junior actors were seen as shy. They didn't give their opinion as much, and they were limited to doing field work, as they were described. There were very interesting descriptions of local and expatriates dynamics, even though there is a very small percentage of expatriates or expats in the coordination group. There was the idea that these dynamics intersect with seniority. So expatriates usually took up senior positions in their organizations. And also they intersect with language, which I will talk about later, because these meetings are all held in English. Some people felt that there was no power dynamic, but everybody agreed that a really deep understanding of the context in Lebanon was needed to be able to participate and have a voice. Gender dynamics were generally perceived positively, and there was high inclusion and representation of women and LGBTQIA+ community. When the meeting formats changed after COVID to virtual meetings, this limited the ability of people to participate. Also, not to forget that access to internet is not good in Lebanon. The further you are from the center, the more you are in a rural area or closer to field level areas, the less access to internet you have, and this can affect the participation. There was a language barrier in the use of English, which reflected the fact that the a lot of the work in the humanitarian sector does take place in English. Many people discussed that they struggled to express themselves in English, and this was especially interesting because most people in the task force are local, are Lebanese or Syrian or Arab or speak Arabic. Okay. There was also an idea with the language that there was a lot of maybe sometimes technical medical jargon, which kind of was exclusionary for PSS actors more in community services, especially since there was most local organizations focused on PSS community work, and the more technical mental health medical organizations and actors were usually like senior expatriate or in international NGOs. And finally, people who had established relationships with the task force leaders had more voice. I will say that, interestingly, many of these perceptions were not shared by the task force leadership when we interviewed them, and actually they indicated that many of these things are not really a problem or not true, and there were things in the action plan, for example, that didn't show that PSS was underrepresented. But despite that, people did share these perceptions, and again, like I mentioned, they did contextualize them into the hierarchies inside the humanitarian system. In terms of participation, there were some actors that did not participate at all in the task force, including Syrian organizations, and this was tied to the legal inability of Syrian organizations and Syrian individuals to work in Lebanon. The voice of MHPSS service users, both Lebanese or Syrian or other, was also not present at all and not represented in the meetings. People talked about being informed a lot, so that means participating by being given information, so getting updates, getting meeting minutes, but they also said that this was seen as a form of validation, so they were just validating things that were already made and that they didn't participate in making. And the bulk of participation happens in the form of consultation, so providing feedback on something that was already decided upon or done by the task force leadership alone, for example. And some people felt their feedback was taken into consideration, but many felt that they did not know what happened to their feedback after they gave it. There are very few instances of partnership or more full participation, like some joint document production or the creation of technical committees. So just to reflect, So just as recommendations, having more equitable funding distribution inside the group, being intentional about addressing seniority biases and language barriers, strengthening partnerships and communication channels within the organization with the leadership and the other member organizations, and of course continued research to look into power dynamics, especially since this is important for trying to move forward in localizing humanitarian aid. And we had some limitations, of course, especially participant availability and staff turnover. And yes, in conclusion, it's pretty much the same as the recommendations. So we're good. Thank you so much.
Thank you. Thank you, Thuraya. Yeah, I did realize we started a bit late, so I appreciate y'all keeping the time. We'll open it up for questions. I'll invite Dr. Kanaan and Suraya if you want to sit by the table. I can monitor the chat for the online attendance, and also I'll leave it up to you all to ask questions as needed. All right. Whenever you're all ready.
Thank you so much for the presentations. I have a question to, I think, Mr. Mohammed. Yeah. Would you reflect more on the differences in knowledge about the mental health between men and women? That was one interesting finding that you shared. Thank you.
So, Mohammed, did you hear that question? Maybe I have to unmute. Yeah.
Yes. Yeah, thank you very much for your question. It's a good question, actually. The males showed significant better knowledge than females. We don't actually know for sure why that is the case. We will reflect on that on the discussion in the full text of the paper. Of course, this was an abstract, not the full text, but for sure there are some, I don't know, some, how could we say that? The social media, the interaction with the social media for the males may be better at these areas. We don't know for sure.
All right. Thank you, Mr. Mohammed. And I think we have a question here.
Hi.
Yeah.
So my question is for Jibril. Hi. So I just want to ask, like, if you looked with your meta-analysis about other like subgroups, or like, because I think you covered like different, like all countries where Syrian could have been reside. So did you like do sensitivity analysis or subgroup analysis, like to look, for instance, the variance between the prevalence in those who are residing in, for instance, high income settings, or like those who are in neighboring country, or who's displaced, or like those who are refugee, or so? If you can elaborate, please.
The meta-analysis was done in two secondary meta-analyses based on the assessment methods that were to measure. Most of the studies were self-administered collected data, and some of the studies were personal interviews with psychiatrists. Those were mostly in Turkey. So there was two meta-analyses performed to see the difference in the PTSD prevalence between two assessment methods, and a total meta-analysis of the total pooled participants data was done. But there was no other meta-analysis because there was not enough data, for example, to cover non-refugee participants, but the main inclusion criteria was that the participants were exposed to the Syrian conflict and has experienced the traumatic, or experience or not, but where they lived in Syria and experienced the conflict. Yeah, there was in the extraction, the data extracted. There was also for how long they have been. But such information cannot be very well informed by cross-sectional study. That's why there is a need to do a cohort study to follow up the progression of such mental health disorders on the timeline, and also to see if we can, what effective can be the interventions in these settings.
Any other? I think we have a hand come up in the back, and then maybe we can go around back down.
Sorry, so just for Dr. Khan, I was just wondering, do you, like, how good is the awareness of the general public in terms of symptoms of PTSD, and do you think that makes an impact on people presenting, or like practitioners diagnosing people?
Excuse me, can you
maybe if you can
to
the mic, it's quite, we can't hear here.
Oh, sorry.
Yeah.
I'm saying in terms of like the general awareness of PTSD symptoms in the population, do you think this, like how aware are people, do you think, about the symptoms of PTSD, and as well like healthcare practitioners, and whether this affects people being diagnosed or presenting?
Yeah, actually the stigma is a major issue in the mental health in general in Syria, and especially PTSD. Many people know depression, anxiety, but there is not a big awareness about what PTSD, although it is highly prevalent among Syrian. That's why one of the recommendation was to address these literacy and programs to to address this stigma and work with it in a caregiver roles and also in educational roles. This can be very crucial to fight the stigma and to address also the literacy in this topic.
Go ahead, yeah.
Thank you so much. First of all, I just want to say that it is absolutely great that we have a dedicated session about mental health during conflict, because as you all the presenters said, you cannot talk about health and conflict without mentioning and researching mental health. So my question is for both of you, Diana and Dr. Khan. If you can share with us some of the maybe lessons learned from the methodology of your work. So I would imagine working with children with PTSD, it's extremely difficult. I mean, I can imagine the bureaucracy behind this, the ethics committees and the approvals and all of that. The same maybe, but differently goes also working with refugees now, Syrian refugees in Lebanon, given also the current political climate and all of that. So if you can share with us some of the lessons learned from the methodology that you both conducted in your research, that could also perhaps help us maybe avoid or try to maybe also adopt some of the techniques that you both used. Thank you.
Would you like to begin? I think this was addressed to...
For both of them, actually, for Diana and for Dr. Khan.
And we do...
It's
okay.
Thuraya, I'm saying Diana. I mean Thuraya, yes.
Questions directed to Diana and...
okay.
You want to start?
Yeah.
You want to start?
Yeah. Okay. For me, I think one of the data that was analyzed was already published, and I didn't have contact with children personal, but I read many qualitative data, which is interviews with the children. It is heartbreaking to read, actually, because when it comes to the data and statistics, it doesn't have the same impact when to read the words on its own expression of the children and the deep of the trauma the scars that can leave in the children. I think there is a need for a different type of methodology, not only cross-sectional methodology. This is something that can provide us with very valuable information to prevent and also to treat mental health disorders. And unfortunately, inside Syria and outside Syria, it is a challenge because the governance is not the same in all the region in Syria, and also it is going to be hard in the refuge countries, but we need to find some solutions to have centric approach to this issue.
Thank you, and thank you so much for that question. I'm very happy to talk about it. So the GOAL project, the overarching project, we did work with Syrian refugees as well as research participants. And as I mentioned very briefly, but in GOAL we were very committed to co-production of the research, because just like in humanitarian systems, in research there is power. We're often coming to very fatigued and over-researched populations, especially refugee populations, because they're more easily accessible. And we sometimes are quite extractive when taking knowledge. So how do we continue doing research while also trying to mitigate this power imbalance that exists? So one thing that we did when doing the work with the Syrian refugees is that after we did our interviews with them and the focus groups and everything, we had feedback sessions on the findings. So we prepared the findings, and we had, before we concluded the data analysis, our participants were part of this, and they were given many options to participate that were more suitable for their time, because of course it takes time. Even if you pay transportation costs, you're you're stopping someone from childcare or from their work day. So we made a video that had all the findings read out loud on a voiceover and written for people who could not read or write, because that was also the case. And people responded via WhatsApp, via voice notes, via text, via emojis. Some people wanted a call, a phone call. Some people wanted a video call. So really centering the needs of the population we're working with in the way that we collect the data, even down to the modality that we use. And when we talked to them and we came back with the findings after doing the initial research, actually, people were very happy about that, because they said, wow, no, thank you. Many people said, wow, thank you. Usually people come talk to us and then they disappear and we never hear from them again. And really they were involved every step of the way, and they were given the option, because not everybody responded, of course. And I think that we will be reflecting on this in a small research note I'd love to share with everybody. And I think that this is one of the first steps towards really, really addressing power dynamics that occur in humanitarian research and humanitarian aid, and kind of really working in partnership with the population that you're trying to benefit, instead of just extracting or consulting them.
And I think Diana.
Yes,
no, it's okay.
I know the question wasn't directed towards me, but I was hoping to come in very briefly on the importance of, ethical permissions. Just because we were conducting a study inside Syria, and maybe at the time there was no formal institution to approach for seeking ethical approval, we prioritized this above all through the Idlib Health Directorate, which represented the northwestern part of the country. In terms of access to health workers, speaking to health workers, we wanted to make sure they knew about the study. They gave their insights on the methodology before we proceeded, and that has been a priority for our team, across studies we've done in Northwest Syria, especially on a topic as sensitive as attacks on healthcare. And I also wanted to add that part of our ethics was making sure that we had a list of mental health resources on hand, because we were speaking to people about and asking them to, in some ways, relive a traumatic experience. So we did have a list of mental health resources in Arabic, online and in person inside Northwest Syria on hand in case that those were needed. And we let the participants know that at any point, in addition to wanting to, if they want to stop participating in the interview, if they feel distressed, that there's also these resources they can access. So just to keep that in mind also when you're conducting interviews on mental health needs.
Yeah, thank you, Diana. And I would like to add, we also at Mahad had an experience with MHPSS needs assessment, and the importance of being ethical and do no harm, especially in a context where there's, as mentioned by Mohamed, lack of awareness, stigma. We see that even when we're training the data collectors, they have to be informed about mental health and what they're looking for as well. And I bring that up because we talk about lack of awareness and all these efforts towards raising awareness. However, we see that there's no, also in Northwest Syria, there's not even the capacity to respond to mental health needs, which is another thing that we should talk about, capacity building in Northwest Syria as well. Just wanted to mention. Any other questions here? Another one over there, yeah.
So I was just wondering to ask Diana, in terms of the research that you've done, it's like, I feel like it's quite clear that there is an understanding that there is a lot of psychological stress within, like the actual healthcare workers themselves realize that they are going through a lot of psychological stress, and there's a lot of coping mechanisms that you've listed. But I was just wondering if there was any kind of formalized initiatives from the healthcare workers themselves in terms of managing their like stress and psychological struggles.
That's a great question. Thank you. At the time of the study, which was mainly around 2021, 2022, I don't remember anyone bringing up any formal efforts to address mental health needs. I think just given the constant stress they were under and responsibilities they had to serve patient needs, so they, as you can see from the interviews, they hardly had time for themselves, I think, to even process what was going on. I think most people use, individual coping mechanisms, just relying on their family, on their faith, on making light of the situation, or convincing themselves that, they had to keep going because there was such a desperate need. But in terms of, anyone accessing mental health care, asking for psychosocial support from the organizations funding them, like Syrian American Medical Society, I didn't hear of anything. And I think it speaks to a lot of the, maybe lack of awareness, let's start there, regarding mental health symptoms and the desire to push on, especially in contexts of deprived resources, feeling like you're solely responsible, especially if you're a specialist in this certain part of Northwest Syria, you're the only person who can meet the needs of patients. So you put an additional burden on yourself without maybe realizing the harms it will have. But I think in the interviews, and this is why it's so ethically, it's so important to have ethical considerations when embarking on these studies, and why we did it so closely in partnership with NGOs working on the ground, is when you're speaking to people, then they start to realize, I have these needs. Maybe we should do something about it. Well, what can SAMS do about this? Can you tell them to do something to support us? And sometimes that came down also to physical, being supported with, for example, more financial compensation, or a guarantee to their families if they were to pass away as a result of an attack. So. I think unfortunately at the time there was no formalized structures, but my hope is that the NGOs that we worked with have taken these research findings into account in their future planning of programming for health workers.
Thank you, Diana. I think we have a couple more minutes. Is there any more questions? We have one in the far back. Yeah.
Hi, thank you so much for your presentations. I wanted to ask, in terms of those power dynamics that we were discussing in the last presentation, so I think it's great that you've highlighted that there is such a disparity between between certain groups of people who are able to communicate better with researchers or communicate their ideas better, or take the fore in terms of these kinds of discussions. But what more could we do to make that a balanced playing field and empower the youth to speak up a bit more, to be less shy, or to make sure the expatriates aren't necessarily the ones that have the most power in these particular situations, because, as you know, that's not, like, some of these power dynamics are not ideal whatsoever. So, and also I appreciate what you were doing in terms of the research and how you were gaining that research and building a rapport with the refugees, because I think that's so important. So how else would we address these power dynamic issues? Thank you.
Thank you for your question. It's really a long list of things that can be done, but I will group them under the idea of co-production. And I don't know if this is something that you're familiar with or not, because I only became familiar with it through my working project goal. And the idea behind co-production is in this push to kind of decolonize, honestly, the way that aid is given and decisions are made about aid, but in addition to that, the way that research is done, to take these really intentional steps from the very, very, very beginning of the decision-making process, when we're conceptualizing what the project is or conceptualizing what the research is, to include the people that are most affected and the community that you're trying to intervene in or you're trying to study. Because what we did was we retrofitted, in this example of talking to the refugees, co-production in the research. We made all the decisions. We decided what we need to look at and how we need to write the topic guides. And when we were done with everything, we went back to them to consult them for their feedback. But ideally with co-production, you would start at the really beginning, in the inception and the idea of the design. And there's many other things that can be done under this really big umbrella, and especially in the research process. So I really do invite you to look it up. There's some really good best practice guides out there. And yeah, I'm sorry this wasn't more specific, but it's a really exciting thing to be able to say, there is a lot being out there, and there are a lot of examples every day. So I hope that we'll have a more co-produced research world soon.
Thank you, Thuraya. And technical working group as well, I would say.
Yeah.
Thank you so much. All right, any other questions? Let's see online, or in the room. I think these are from before. All right. Well, I appreciate all the questions that came in and the presenters for their time. Thank you for this session. And yeah, we can wrap it up now. Thank you so much.
All right, good afternoon, everybody, and welcome back. We're going to start the last part of the conference today with our second keynote speaker, Dr. Reem Turkmani. For those of you who don't know Dr. Reem Turkmani, she is a research fellow at the Conflict and Civil Society Research Unit at the Department of International Development at the London School of Economics. She directs the Syria Conflict Research Programme at the unit there. Her policy-oriented research work focuses on identity politics, legitimate governance, transforming war economy into peace economy, and the relationship between local and external drivers of the Syrian conflict. Dr. Turkmani is a member of the Women's Advisory Board, the UN Special Envoy to Syria, and sits on the advisory board of airwars.org, which monitors the international coalition strikes against ISIS. She's also directed the project Crowdsourcing Conflict and Peace Events in the Syrian Conflict, which produced a detailed database of instances of violence and peacemaking. Dr. Turkmani takes the results of her research to the policy-making table and has been invited twice by the Foreign Affairs Select Committee in the UK Parliament to give expert evidence on aspects of the Syrian crisis and the UK's foreign policy. In 2016, Dr. Turkmani wrote a chapter on the EU policy on Syria as part of the report From Hybrid Peace to Human Security, Rethinking EU Strategy Towards Conflict. And this was officially presented to the High Representative of the Union for Foreign Affairs and Security Policy, Federica Mogherini, as part of the Mogherini Global Review of EU External Strategy. I won't go on too much, but I will let you now speak. Thank you, everyone, and we will continue with you.
Great, thank you so much. Thank you for the introduction. My voice is heard, is it okay?
Yes,
all fine? Great, fantastic. Well, thank you very much for the introduction. Thank you all for being here this afternoon. And big thank you for King's College and R4HSSS, I wrote it here, for inviting us to be... for inviting our research unit to be partner in co-organizing this very important conference. Really what you're doing is so important, it's so impressive. I was so impressed listening to Preeti Patel this morning, introducing all the achievements of the program, all the research papers, all the scholars who were graduated through this program. This is really a program that is not only producing knowledge, it's saving lives and alleviating humanitarian suffering on the ground. So thank you all for everyone involved, and thank you for the organizational committee of the conference. I know you've been through a lot, and you had to do this twice with the postponement, so thank you for all your efforts. I have to say, I don't know of any other research program that is so focused on particular sector in Syria. This is the only one I know of, and I wish we have similar programs addressing, for example, the issue of education and or agriculture. There is much need for this indeed. We heard also through the presentation what wonderful work the health system is doing in Syria in various areas and very, very conflict context. And we heard from many, including Ayla, how that as the needs are increasing, resources are drying out. And in these times, this is when we need to think of efficiency. How can we make the system more efficient? Now, Professor Preeti Patel made a comment in her opening speech about the cross-disciplinary collaboration that the program is pursuing, and one of these collaboration is working with our group at the base at LSE, literally across the road, not just across the discipline, on this within this framework of R4HSSS. So when I say we here, like we're collaborating with the program, I mean a group of researchers based at the LSE, including myself and some of my colleagues who are here with us, including Mazen Ghoribe, Zaki Mahshi, and Dr. Muzer Khalil, who is now also working with King's and with us on this program. It's our view that health governance in conflict zones, particularly in Syria, cannot just be seen as a technical issue. It cannot just be measured using the metrics of WHO and the international frameworks, important as they are. this also has to be seen through the lens of political science. And this is our contribution to this program. This is what we're trying to invoke, with particular focus on institutional legitimacy. We think that approaching this issue from a political science perspective will bring to the attention some of the key issues that could increase the efficiency and the fairness of health system in Syria and in conflict zones in general, but also bring the attention to the very, very important public good value that a legitimate, functioning health sector can bring to the overall country, to the stability, to the peace and well-being in the country, not just focusing on the health benefits. These systems, I mean, as we all know, we heard these health systems operating in a very, very complex context, and you just cannot ignore the politics. It could be under a very authoritarian control with the state capture, like in the regime areas or areas of limited statehood or no statehood whatsoever. And you find a bottom-up system that is meant to be driven by civil society suddenly has to really not just fill the gaps where usually civil society work, it actually not filling the gap of the state, it's behaving almost like it is the state. It has to step into the area of really caring for the public interest, and not just for its own, the gap that it's trying to address. And this is a very, very political issue. So you see transformations of these institutions suddenly from something that is really civic, bottom-up initiative to something that has to think like a state and act like a pseudo-state. Within this very complex context, it's very important to understand how these institutions are negotiating their relationship in this complex context. How are they protecting their civic space? How are they handling the authorities in charge, the armed actors, the political actors, always changing the whole time. So it's really important to understand this role, especially the interlocutor role, because we've also seen that role coming handy a lot during crisis times, including during the vaccine campaigns, when we've seen their ability to talk to everyone across all the divides became very, very valuable. In particular, we think it's important to focus on the question of institutional legitimacy of healthcare systems. This question has been the area, subject of increasing interest in the last 2 decades in the literature in general, the legitimacy of health systems, international and national. Particularly after COVID. I mean, after COVID, it became so evident that people will respond and listen to the institutions they trust. Trust suddenly became a key issue after the pandemic. And we've seen in Syria the last 13 years, several models of health systems for, forming, collapsing, forming again, working across lots of transformation of public authorities, collapse of authorities, forming through different governance model. They're operating through a governance mess. But throughout this mess, we've seen different models emerging. We heard today from Zaidoun about the kind of 3 main models, like the bottom-up, top-down, and the hybrid model. And what we're trying in our research project is really to understand the role of legitimacy within these 3 different models. Are people likely, how legitimate they see these different models? Are they likely to comply more with one model than the other? But let me, before go into the details, just to bring to you why it is so important to bring the legitimacy to the study of health governance in conflict zone in general, but particularly conflict zone. And all these issues we've seen at play in Syria, but they're also all well established in the literature. First one is it's voluntary compliance. If there is legitimacy, then people will voluntarily comply with the instruction they're given. Authorities tend to resort to coercion or laws and regulations or to consent to generate compliance. Generally speaking, the more an institute is legitimate, the less it has to resort to coercion to deliver to get compliance from people. This is why legitimate institutions are really key for any type of service delivery, but particularly in conflict zones, an area like Syria, where it's not clear what the law is, and it's not clear who is actually protecting this law, and who is enforcing this law, who has the coercive power, and we don't have alignment between the health system and those who has coercive power or those who are trying to impose local law. So that lack of alignment also makes it even more important that the health system itself on its own, not like usually in a state, like if you're studying a state, you study the legitimacy of the state and then you think of the health system that is associated with it. But here, we have to focus on the legitimacy of the health system itself, because if people see it as relatable, trustable, then they will comply with the instructions. And again, I mean, we know how important this voluntary compliance during time, not only in normal days, but also during the time of crisis, like during COVID. It's also legitimate health systems also are more likely to be trusted, accepted by the local community, particularly in conflict zone, because this is an area where fear, suspicion, misinformation are rampant. And trust in healthcare then providers and facilities become really essential for people to seek and accept medical care. Sometimes if you don't trust the system, you're not going to go and ask for care even if you need it. Legitimate health systems also foster trust and cooperation between health providers and the local community in general. So if the system is perceived as legitimate, fair, transparent, accountable, they're more likely to also seek medical assistance. So legitimate health systems do play a vital role in preventing and controlling the spread of disease, because also this is where they come to play when there is a spread of disease and you really need people to comply with all the prevention measures and the vaccination instruction and all of that. So that's first thing is the issue of voluntary compliance. Second issue is bringing much needed international support. International organizations tend to trust more legitimate institutions, especially in a conflict zone where you don't know where the money is going to go, who is trusted, who's not. So they favor cooperating with an institute that is seen as legitimate. And that means not only financial support, but also international collaboration with international health organizations. Third and last, stability and peace building benefits. So legitimate health systems can contribute to stability and security in conflict zones through different ways. First, by providing equitable access to healthcare. Legitimate health systems are better positioned to provide consistent and equitable access to healthcare services across all the community, across all the divides. But also, building legitimate institutions in general brings stability, brings peace building to the area, not just, as I said, to the health sector itself. So the system itself, the health system itself, can serve as a symbol of governance and authority, reinforcing the presence of legitimate state institutions and promoting social cohesion. Now, in our research, we try to understand all these issues, how do they come at play, as I said, in 3 different areas in Syria. We looked at all the different models that are there, like the top-down, the bottom-up, and the hybrid. And we wanted to understand how legitimate people see these institutions, how much are they willing to comply with their instructions. And the problem is that there isn't a framework there that is able to see this legitimacy in such a complex conflict where you really need high resolution lens. And we already in our group, we've been developing a model that can see legitimacy in a very granular way, because even for any other type of legitimacy, not just for health sector, the institutional frameworks that are there, they're very state-centric. Everyone's looking at the legitimacy of the state, but within a conflict, where is the state? In a zone like Northwest Syria, who exactly is the state? The whole public authority is fragmented. So it's important to have a framework that is able to see this fragmentation and able to capture the fact that nobody knows what is the law. I mean, all the frameworks of legitimacy, capturing the sources of legitimacy, they emphasize the importance of the law as a source of legitimacy. Did you assume power through legitimate means, lawful means? And again, what are the laws here? So we try to compensate for this by developing a very granular model that is able to take into consideration the context of conflict zone. For example, we try to understand whether this institution is adhering to local norms, whether they resonate with local values. What do people think of them and why? Do they think that their cooperation with the international actors is good or bad? Does it make them more legitimate? Does it make them trust them more? So we adapted this model to be able to generate a framework that is capable of capturing the sources of legitimacy, particularly in conflict zone. And it is thanks to Dr. Monzer Khalil, who's leading us on this research, and he's the one who took the leadership in developing this framework through his understanding of the nuances of the health system in Syria. Hopefully in the coming few months, we will publish the paper and the framework will be available, and we hope that it will have applications outside Syria. The question of performance also becomes very important in such context, and that's another thing we're trying to understand. So generally speaking, there is this belief in the literature about legitimacy that if there is something called virtuous cycle, that if you're an institute and you deliver your services in a good way, then people trust you more. That makes you more legitimate. And if you're more legitimate, then people will comply more with you, and that also increases your legitimacy. So there is a whole cycle, which means really good performance will feed back into your legitimacy. So we're trying to test whether actually the cycle works everywhere in Syria. And initial finding are saying, well, it doesn't work well in every area. In the areas where the source of legitimacy is seen to be coming from the outside, even if you perform very, very well, people still don't think you're legitimate. It doesn't matter. And that is a very important thing to keep in mind. We've seen also people trusting the bottom-up health governance system much more than the top-down one, and they're willing to comply with them much more. In the hybrid areas, we've seen some of the kind of mixed results. I think in the hybrid, people also appreciate sometimes the external role where it brings different values. I think Zaydoun spoke about this, how depending on the time, different actors can bring different values to these systems. Like when the time of emergency, you need the flexibility of the bottom-up system, but maybe for long-term thinking, you need an actor who's able to act like more from the top-down. And we think there's a lot of learning that we can take out of this. I mean, I'm going to finish just by signposting some of the issues that we can take outside Syria to the wider scholarships on health system and conflict zones, especially that the next panel is going to discuss this issue. We certainly don't want all the learning that is generated from Syria to be just confined in area studies. This is something that should go and bring benefit to different areas in scholarship and in developing theory. And one of the issues that can be taken, let's say, is this framework that we are developing and the emphasis on the issue of legitimacy, which means also the emphasis on supporting governance. I think that we heard from Ayla how actually support from donor side to governance of the health system have gone down. And this is really, it had very, very bad effect on just health, what was really exemplary health system model in Syria. But once that with support for governance was withdrawn, we've seen more fragmentation and we've seen more focus on life-saving aid rather than on the governance of the system. And we really think that it's important to bring that back and to focus on the bottom-up system. Another learning, I think, is how health system can protect civic space. Particularly, I think one of the innovative systems that emerged in Syria and Northwest Syria is the Health Directorate, particularly the Idlib Health Directorate. Because as we're talking about legitimacy, it's important to emphasize that this is not just a bottom-up system. I mean, the Idlib Health Directorate, actually, if we observe the way it was formed, the way it's designed, where it is going to draw its sources of legitimacy, we understand that this is an institute that actually understood the scene very well and protected itself through this mechanism of legitimacy. Because they knew that in such a conflict environment, you're going to have so many actors changing heads, you're going to have extreme actors, God knows who, and you don't want to be, as a directorate, to have one person on top who can be appointed and then taken out, and then appointed, and we see this in the regime areas and other areas. So they designed it such as the head of the directorate is elected from the general, I have to finish. Yeah, don't worry. So this design to draw your legitimacy from the bottom actually is a very important one to protect that civic space, protect its independence and its durability. And finally, I think one of the learnings we can take is how the system works, not on its own, but within a very complex civic ecosystem. We heard from Zaidoun how, like, the response to the earthquake revealed that. Suddenly you realize how the system is not working on its own, is so well connected to the diaspora, to the local community, how everyone just chipped in and work together, and understanding the system together, not just as an institution on its own, is also another very good, important learning that we can take out of Syria to the wider scholarship. And I'll end here. Thank you.
Thank you very much. And Hamze, who was working with you on that study, was telling me that.
Yeah.
Thank you. Thank you. Just want to make sure if Tamam is with us. Online.
If you can take a seat. Yes, take a seat.
Oh, okay.
So thank you very much for joining us in the last panel of our conference today. My name is Munzir Khalil. I am an orthopedist by training. I am a research fellow at R4S Travel S, Awesome and LSE, London School of Economics and Political Science. Also, I'm a co-founder of many quasi-governmental institutions in Northwest Syria and hospitals, including Idlib Health Directorate and Al-Amal Hospital for orthopedic surgery. So the aim of this panel is to discover any possible opportunity to use the produced knowledge in Syria to support other conflict-affected areas, such as Yemen, Sudan, and most recently, Gaza. The discussion about this topic started many months ago, when we have involved in evaluating health governance in Syria in general and in Northwest Syria in particular. We used most of existing frameworks to evaluate health governance in Syria, such as UNDP, Sadiki, and WHO. Unfortunately, after finishing this exercise, we were unsatisfied about the results. We were unsatisfied about the reports that we got, because we felt as practitioners, as people who involved in working in conflict area for more than a decade, that there is something missing. There is a gap actually between our understanding to the meaning of health governance on the ground and our understanding and our results, our findings as researchers using the existing framework in the literature. So we established actually this work to evaluate some frameworks which can be more relevant to conflict-affected areas. So the first one was the legitimacy framework we developed together with Reem Turkmani, Zaki Mahshi, Mazen Ghoraibi, and Preeti Patel. And the second one, I'm working mainly on this framework with Zaidoun Zawi about the health governance in conflict-affected areas, a framework to evaluate health governance in conflict-affected areas. Because we believe that existing framework have wrong assumptions. The first one, they suppose that there is a legitimate government in place, which is not the case in many conflict-affected areas. Sometimes we don't have a legitimate government in place, or we don't have a government at all. The second one, they suppose that we have one health system in place, which is not true. In conflict area, we have something, we call it multipolar health system. We have parallel health systems. So probably we have to choose which system we are going to evaluate or describe. The third one, they suppose that we know the roles of stakeholders in this area, which is again not true, because in conflict area we have untraditional roles and responsibilities. So our new framework includes legitimacy core principles and legitimacy enhancer principles, because we want to value the people voice in this area. We want to put people in the heart of our work. So legitimacy is always about people perspective. And also we included more dimensions to our framework, including power dynamics, because we have different pools, so we need to think about power dynamics, power phases and power dimension, roles and responsibilities, legitimacy, and the meaning or explaining what the meaning of multipolar health system. So we thought that using this framework will help us actually to understand health governance, not just in a situation like Syria as conflict-affected area, but also in other conflict-affected area, will actually support us to enhance the aid effectiveness in this context, will enhance sustainability of health systems, will enhance the resilience of health system and conflict-affected areas. So this panel actually to discover any other opportunities from the significant work that has been done in Syria in different areas, including health governance, medical education, and other, to see how we can take benefit from this knowledge, actually, this produced knowledge in Syria, to support other conflict-affected areas. We will start with introduction by our respectful and exceptional, actually, panelists today who has great experience working in providing like health services and also in working on health governance and postgraduate medical education and training in conflict-affected area. So I will ask Mazen firstly to introduce himself, please.
Thank you so much, Mohamed. I already did introduce myself this morning, so just quickly, Mazen Ghariba. I'm a member of the Syria team working alongside Zaki, Reem and Munzer on the LSE's Conflict and Civicness Research Group, focusing on the issues of local governance, civil society, political legitimacy, and transformative resilience.
Thank you, Mazen. Louise?
Well, I'm Louise McGrath. I'm the Deputy CEO of THET, which is a UK non-governmental organisation that stands for Tropical Health and Education Trust. And firstly to say what a great pleasure it is to be with you all and so many esteemed colleagues who are doing some wonderful work. It's a real pleasure and honour to be with you, so thank you. And just to say, THET, for those who don't know, which I'm sure is many of you, is a UK NGO that's been working in northwest Syria for the last 19 months. And just to give you a bit of background to the organisation, it's an organisation that focuses on health workforce development, so particularly models and approaches to strengthening the health workforce, but also the health system within which that health workforce operates. And we do it through a model that we call health partnerships. That's by linking and facilitating partnerships between health institutions across borders, very much with the idea of mutual learning between those institutions and those partners and across those geographies. So yes, we've been working in northwest Syria for the last 18 months, working in partnership with SPOMS, with the Idlib Health Directorate, with the Health Information System Unit and others, to respond to some of the priorities identified by those partners to strengthen postgraduate medical education and to start to look a little bit at undergraduate medical education. So we're at the very early stages of our work, but it's, yes, a great pleasure to be here and talk about some of it with you. Thank you.
Thank you, Louise. Thank you, Mazen. So unfortunately, we should have Tamam Al-Audat with us, but for an emergency situation, he is not able to join us, so we'll continue. The panel will be kind of questions and answer. We want this panel to be more like interaction, more than just like a presentation. I know that you're already tired a little bit after this long conference. So the first question for you, Louise. You are now, like I said, collaborating with some Syrian NGOs, including SDC, SPOMS, and others, to provide postgraduate medical education and training for health workforce in northern Syria. So my question, based on your experience so far in Syria, what this experience, how this experience actually can support your approaches and interventions in other conflict-affected areas? What you bring with you from other conflict to Syria, and what you can take from Syria, from your experience here to support other conflict?
Thank you, Dr. Musa. Well, firstly, to say, of course, every situation, every context is different and has its own specific characteristics and challenges and opportunities. So, of course, there's no standard approach that can be just taken from one to the other and vice versa, as you all know, of course. But I think certainly as we started our work in northwest Syria, we were already basing some of our approaches and the steps we took on our experience of working in partnership in many other contexts, and how to form partnerships, how to support partnerships, how to sustain partnerships. But also in terms of conflict settings, we've been working in Somaliland for many years, which is a slightly more stable conflict setting, but it is a situation of instability. But I suppose the setting that was most relevant in terms of more recent experience that has helped shape some of the way we've started our work in northwest Syria is our work in Myanmar. We've been working in Myanmar for many years, and following the coup that took place in recent years, we've had to suddenly change the way we work with partners on the ground, because I don't know how many of you are familiar with the context in Myanmar, but the health system was shattered by the coup as the military took over the existing health system, and the majority of the health workforce stood aside from that system and has tried to set up separate parallel systems. So through that experience of working in Myanmar, what we learned was, well, we can no longer work with the existing institutions that we'd previously worked with. We need to find new ways of engaging with a number of those health workers who are setting up or trying to work in new ways with to provide services to the population, to provide medical education. So we had to first with partners on the UK side, because lots of UK institutions have been partnering with peers in Myanmar. We've had to find new ways of coordinating amongst ourselves and then coordinating with different members of the Burmese health workforce in Myanmar. So I think working virtually has been a key mechanism, but also finding different routes and different mechanisms to communicate, knowing the sensitivity and the fear that many of the health workers have faced by engaging with us and in networks with each other outside of the official systems. So I mean, we also learned so much from COVID, to be honest, in terms of how to work virtually. So I think working virtually, but also recognising sensitivity, recognising the importance of trust. I think that's a term I'll focus on a lot today. I think trust and the fact that those relationships were based on trust and that enabled people to continue to work together, I think really enabled that work to continue. And that's fed into the work we've been doing in Northwest Syria, recognising how very important trust is in building relationships and working in partnership with institutions. So I think we've certainly brought some of those perspectives into how we work in Northwest Syria. But in terms of what we're learning from the experience of working with partners in Northwest Syria, and there's so much we're learning. I think it's an astonishing setting in terms of what people have been able to do and how they've managed to turn things around in such a challenging context with the fractured health system, the fear and the insecurity, and of course the distrust amongst the individuals working there, and the depletion of the health workforce. So I think we're learning from partners and peers different models and approaches to responding to issues on the ground. So for example, some of the models of responding to postgraduate medical education, we're now taking that into some of the discussions we're having with partners who are at the early stages of setting up postgraduate medical education. So for example, in Somaliland, I was there last week with partners who are keen to be establishing some sort of mechanism for postgraduate medical education. And we're talking about the model of SPOMS and the Syrian Board of Medical Specialties, for those that don't know. I'm sure many of you do know. So we're using that as an example of this is what's happened in Northwest Syria. This is how this has been set up. We're not saying this is the perfect model or the only model, but it's one of the models that can be considered in a context where partners are trying to think about how they can set it up in where they haven't got everything necessarily in place, or they can't start with a perfect finished model. So I think there's lots that we're able to gather and learn from the Northwest Syrian context that is really going to benefit our work and the work of our partners. So the other thing to say is, we work with and through partners, so we're working with the Syrian Board of Medical Specialties in partnership also with some technical partners who are working, providing particular technical expertise. So that includes the Royal College of Emergency Medicine, working with the Scientific Committee for Emergency Medicine within SPOMS, and similarly the American University of Beirut, the Obstetrics and Gynecology Department, working with the Obs and Gynae Scientific Committee in SPOMS. So those institutions bring their experience of working in other contexts and also are taking what they're learning from working with SPOMS back to the other areas that they'll be working in. So I think sharing learning across borders and across contexts is very much at the heart of what we do, and I think it really is a very rich space to be learning, working with the partners in Northwest Syria. Thank you.
Okay, great. Thank you, Louise. So Mazen, you are an expert in governance and expert and researcher in governance topics. You have worked on legitimacy of health system, on ecosystem, on health governance, and other topics related sometimes more to like local governance. So based on your experience in Syria, what are like lessons learned we can take them from the Syrian case to support other conflict-affected areas, to support systems in other conflict-affected areas?
Thank you so much, Dr. Munzer. Yeah, first of all, as my colleague Reem said, that in the Conflict and Civil Research Group, we try to look at the health sector and health actors from a different perspective. So we try to complement the already brilliant work done by King's College and Alfred HSS by also analyzing the political and social angle and impact of health actors and health governance inside Syria. For instance, I would argue, like a few years back, I wrote my dissertation on the social and political roles of health actors inside Syria, and I would argue to this day that doctors and health workers in Syria are the most influential civic actors in Syria. They play significant political and social roles, local mediation roles. I will give you many examples. So one of the case studies I was looking at back then was the local mediation roles of health actors in eastern Ghouta during the besiegement of Ghouta by the Syrian regime. There are many instances where, for instance, when the civilians were given a chance to nominate representatives to negotiate with armed actors and the regime, they mainly chose doctors. When the inter-Ghouta clashes between two of the most influential non-state armed groups happened, regional powers tried to mediate between these two powers, and they failed. And the Unified Medical Bureau of Ghouta actually managed to stop that clash between Jaysh al-Islam and Falq al-Rahman back then by capitalizing their social power and their political clout. They did this in very innovative ways. They issued statements pleading to the public, saying that if these clashes continue, we will not be able to operate. We will have to close our medical centers and hospitals. Within hours, actually, people took to the streets in Ghouta and demand the end of these meaningless clashes between these armed groups. And doctors in Ghouta actually are the ones who took the lead on these political mediation roles. And these roles continue to happen till this day. So looking at these roles don't, of course, stop at these local mediation roles, but also they played a significant role in changing the local governance dynamics in Syria. For instance, I would also argue that the governance of the health system, the health sector in Northwest Syria is the most successful governance system that we have currently in Syria. If not the most successful story ever during the Syrian conflict. And of course here, I know Dr. Munzir doesn't like me to say this, but I think Dr. Munzir was one of the most, if not the most important key actor in actually doing that. And I know that you don't like me saying that, but I enjoy turning your face red sometimes. So why it was very successful? I will try to list some of the factors beyond, of course, their amazing capacity in providing medical services. Looking beyond their medical roles and medical services, I would say there are many factors. I will try to highlight 3 of these factors about why local governance or the governance health system in Northwest Syria was the most successful one. I would say the first one is that they were aware that in order for this sector to succeed, we need to build on the institutional memory of health workers and actors in Northwest Syria, meaning that we need to build on the institutional continuity of the health system that already existed in Syria. So what they did is that they looked at the health system that already existed in Syria for decades. They took what works and what doesn't work, and then they took the working behavior and practices of that system, and they put it in the context of Northwest Syria. Giving, of course, that most of the actors of the system are doctors, nurses, and other health workers who already are familiar with the system. So they didn't invent an entire new system. They actually tried to enhance the system that already existed. And that played a very important role in the future. And they were very innovative about that. The second factor, I would say, was that from early on, medical NGOs in Syria, specifically what we call the big medical NGOs, so here including SAMS, OSM, SEMA, PAC, for instance, they knew from an early stage that medical services, health services, the provision of health services, cannot be sustainable without the existence of a legitimate governance structure that could regulate, supervise, and take the lead of these services. And they used and utilized their bargaining power, and here we're talking about huge bargaining power of these medical NGOs, to negotiate with major donors who didn't want to engage with the governance structures, namely Idlib Health Directorate. And of course, they also work with the local communities and local stakeholders for this. So here we have an example where medical NGOs said, look, NGO-driven response to medical services is not sustainable. It's very limited, it's very disorganized, and very disconnected. In order for that to be sustainable, we need to have this complementarity with the governance structures, not a competition or unnecessary competition with them. And this kind of partnership between the governance structures, health governance structures, mainly Idlib Health Directorate, and medical NGOs played a major role in actually sustaining these services. Now, of course, they also use their bargaining power to open up new spaces for the governance structures, the health governance structures. For instance, I was talking to Dr. Hamze and Zaidoun earlier about the resistance of UN cluster system to include the Idlib Health Directorate and other health directorates. And medical NGOs in Syria took a stand, said this doesn't work. If you want if you want needs assessments, and if you want to actually reflect the priorities of the health system, these governance structures need to be on the table, sitting on the table. They're not beneficiaries. They're actually taking the lead in all of this. And they changed the culture within the UN cluster system to include, the first time ever, a representation of a governance system, Idlib Health Directorate and other directorates in the cluster system. Now the third, I would say, or the fourth, important factor is the bottom-up approach to health sector by the Idlib Health Directorate and other affiliated NGOs. What they did back then, and correct me, Dr. Munzir, was you were the one who's leading this. So it's very weird to talk about this when you were standing there looking at me. So when that happened, what they did is that they engaged with local stakeholders, with every relevant local stakeholders. So with hospitals, hospital managers, with mobile clinics, with every relevant health actor in Northwest Syria. They engaged with them. They made representative bodies. All of them felt, which is now what I'm going to highlight, felt the ownership of all the policies, practices, rules and regulations that came up from this engagement. And because of that ownership, because they were part of this, these policies and regulations are still implemented to this day, because it came from them, from brainstorming. So they have this kind of local ownership toward their product, which is the local knowledge production that Dr. Munzir managed. And that actually played a major role in the sustainability of the health sector today. Given the situation in Idlib, the Idlib Health Directorate, for instance, is an autonomous, it's completely an autonomous, I would say, structure. Of course, de facto authorities, they always try to influence, but they can't, because they simply know that this system is legitimate enough that they cannot actually replace it with any other system created by them. So the legitimacy of the Idlib Health Directorate and the health sector in Syria managed to keep HGS aside. And unfortunately, that was not the case in many other sectors. I will stop here, and I know there are many other
Thank you. Yeah, thank you, Hamze. So, Louis, how we can establish and sustain an equitable partnership between donors, NGOs, and local actors? I know that you are already involved in many discussions at different levels. So, if you want to give some advice, maybe to most important donors and local actors, what that would be?
Well, I think it's a real challenge. I mean, it's something we should all be striving for, is equitable partnerships. But I think, as you would say, what does that mean? And it has to have substance behind it. And just to say, to set the scene, I suppose, partnerships are at the heart of what PhET is about. And we have established 10 what we call principles of partnership, which are based on principles of aid effectiveness but adapted to the partnership context. And a number of those focus on issues of equity. So there's one around being mutually respectful and reciprocal, which I think is, I'll come back to that, but I think it's really key. And the other is about promoting equity within the partnership and within the programme of work that the partnership is working on. Obviously, those are nice words, but they have to mean something. And I think it's really about, firstly, coming in and making sure you from the very beginning, you're claiming and really clearly presenting the desire for this to be a mutual partnership. And that means listening to the partner, listening to what the priorities are and responding to that, not going in with any preconceived ideas. It means recognising the mutual benefit of any partnership. Both partners will gain something from working together. And it means being reciprocal, so really thinking about what's of interest to the partner, what's of interest to us, how can we come up with something that makes sense. And I think building on, Thurai, your suggestions and your comments earlier around co-production, I think that's something we very much have at the heart of our model of partnership, is that co-development we would talk about. So we talk about a partnership coming together to respond to the locally identified priorities, but then to co-develop any response to that, and to make sure there are appropriate roles and responsibilities and governance structures within a partnership that clearly spell out the equality within the relationship. So it's not just words, but there are structures and systems agreed and spelt out to really make sure that happens. Of course, it's not easy, it doesn't always happen straight away, and it takes time. And I think just going back to that issue of trust earlier, I think that is at the heart of an equal or promoting equality in a partnership. It's building trust. Without that trust, of course, you're not going to really feel comfortable to be equal or feel equal. And I think, particularly in a context like Syria, Northwest Syria, the issue of trust and people feeling safe to express their feelings or their concerns or to feel open, it's a major challenge. So I think really building those relationships, really trying to understand the perspective, to build that trust is at the heart of an equitable partnership, but recognising that it's not easy and it's not straightforward. So we know it's a challenge, but it's something that certainly in our work we really want to drive and promote. In terms of with donors, that's a slightly more challenging issue. I think certainly in our work with donors, we always reinforce what we understand the partners want, if we're having a discussion, and to bring the partners into the discussion with the donor. I think there are often limitations to that if the donor has a particular remit, a particular pot of money for a particular purpose. But then it's us deciding, well, do we want to take that if that's what the local partner wants or not? So it's being conscious of what you're taking and what conditions and making sure that is in line with what the partner also wants or doesn't want.
Lois, do you think that building trust in conflict-affected area is more difficult than stable area? Do we need to invest more efforts to build such a trust in conflicts?
Most definitely, because of the challenges that people in conflict-affected areas have faced and continue to face. So I'm sure for people in Northwest Syria, it's difficult to know who they can trust or should trust. And so therefore, why should they trust me or Thet or us without having a clearer sense of who we are? So I think it takes perhaps longer to build that trust. You need to invest more time, be very patient and understanding of the challenges. Also trying to understand those conflict or those challenges that those stakeholders are facing, so that you can try and give time and space to build that partnership.
Okay, thank you. So Mazen, for those who are inspired today by today's presentation to do kind of research or to work in conflict-affected areas, what advice do you have for them? What challenges they should try to avoid while working in conflicts?
Thank you, Munzir. I don't think I can give an advice. I need many advice myself. I need plenty of advice. But I can maybe reflect on my journey so far in this field. I believe most of us doing or wanting to do research in conflict areas, specifically in the MENA region, we'll find ourselves that we're gonna do a significant work remotely, and which means that we have to rely on a network of local researchers inside the countries and the context that we want to work with. And the relationship with the local researchers is very, very important. All this morning we were talking about co-production, the co-production of knowledge. These local researchers that we work with, they're not just data collectors, they're not just local voices to give legitimacy to some of the publications. They are co-researchers, co-authors, co-producers of knowledge. They need to be acknowledged, they need to be part of the entire process of research, not just asking them to do interviews and focus group discussions and that's it. Usually these local researchers, they take huge risks in terms of security and personal risks. And we need to enhance the atmosphere and the policies and procedures to protect these local researchers. So for instance, we are trying to do that in our group. We have a duty of care policy to our local researchers inside of Syria. And we're trying to lobby to have this kind of duty of care policy for local researchers at the school level, not as our kind of unit level. And I believe this needs to happen in all universities who has departments or programs working in conflict areas. It starts by acknowledging local researchers as co-authors and co-producers of knowledge, whether giving them a co-author title in the papers, or at least an acknowledgement in the body of the publications. They need to be well compensated as well. Looking at some of the amounts paid to local researchers inside Syria, because this is the context, it's embarrassing. It really is embarrassing, and it feels like we're taking advantage of a vulnerable group that cannot actually express their demands, and they need us to do so. So these duty of care policies, I would say we have to fight for that. And again, if someone wants to continue on this path, we need to challenge a lot of what is written about our context and our countries. This is actually what got me into academia in the first place. I was furious about the amount of irrelevant information about Syria from Western academics or Western journalists who've never been to Syria before, or doesn't know anything about Syria. This is when I realized that our local knowledge matters. We know the country, we know our country, and we know our context, and we have this lived experiences there, and we need to challenge a lot of what is written about our context and about our countries. Looking back now, reflecting on, I would say most of the peace studies written in Syria, they're irrelevant. And they are very top down, they consider very kind of Western normative perceptions of what peace is and what peace building means, and as if the conflict in Syria can be resolved by a dialogue between conflicted parties, and that's it, without looking at the root causes of the conflict and the different manifestations and transformations of that conflict. So I would say that we need more people writing about their own context and their own countries, because we need to own our kind of our local knowledge, and we need to challenge what is written about us in many of the publications and many of the academic institutions. So I don't know if that's an advice or not, but this is kind of a call for action.
Thank you, Mazen. So now I have the same question for both of you, and it is a tricky one, so forgive me in advance. So you know that Syria now in a transition phase between a humanitarian and early recovery conflict and early recovery, and many NGOs try to get some fund for their proposals. I read recently many proposals related to research and capacity building and so on. So I found this attractive term many times in this proposal, equal partnership. We believe in equal partnership. I tried to understand actually many times what the meaning of equal partnership in this context, but I was not able to do so. I put to myself 2 indicators just to try to understand what that means. Fund allocation between different stakeholders and decision making. In some projects, around 80% of fund goes to the first implementing partner, which is probably a Western NGO or a prestigious university, according to the type of the project, or a UN agency. And then we have NGO, local NGO. In our example, should be like a Syrian NGO in neighboring country, Iraq, Lebanon, Turkey. And then we have the local actor or the local stakeholder. In some projects, 80% of fund go to the first and second implementing partner, and less than 20% go to the local partner. Regarding decision making, I found that sometimes most, if I don't want to say all, significant decisions are made at the level of the donor and the first implementing partner. And I guess there are some decisions, maybe logistic and operational decisions, at the level of the like Syrian NGO in our example, in neighboring country, and I guess almost zero decision power at local level. So in this context, what the meaning of equal partnership? Is it better to use other terms? Is it better to start using like terms such as power sharing, power transition, or it is like the situation is more complicated than this and more worse, and we have to like think in totally different approach? How local actors in this context will feel ownership about these projects, and maybe most important, even who owns actually all the knowledge and data that collected from Syria over the last 13 years? Are this knowledge and data based like in the hands of national or local stakeholders, or probably is at the level of donors?
I'll happily try and go first. Well, I think firstly, I don't know what that should be called, that description you gave of a setup of a project, but it certainly isn't an equal partnership. And I would say, whether we find a name for that or not, we should try and push against that sort of setup of a project or program. I think in any project or program, we would want it to be driven by what the local partners are identifying as the priorities. There are obviously limitations as to what then can be responded to or presented to a donor, but that in any program that should be the case. How that can be driven, that's obviously, it's difficult, particularly for the local NGO to be able to drive that. But I think donors probably could play a stronger role, and we probably should advocate and lobby donors to be making sure that local institutions have had a role in the decision making about a project. Because obviously we can't change the way all NGOs work, but we can perhaps lobby the donor community. And that's something we can certainly take on ourselves to do, to say, are you ensuring that the local institutions have had an active say in what this programme should be about and have an active role? But that's certainly a role I would propose that the likes of us could take forward, but certainly in the projects we run, we would always want to have engaged with the local partners, with, in this case, SPOMs and others, to understand what their priorities are, and do they agree with the priorities we're then presenting to the donor, and are they happy with the way we're proposing to implement it. That's not to say that our projects are perfect, and there are always things that could be better, and certainly in terms of the flows of funds and those things, there are things we need to improve most definitely. But we would certainly always aim to have made sure that whatever we're presenting to a donor is based on the priorities identified partners and agreed by those partners. Yeah. In terms of the data, yes, I think that's a real challenge, because particularly in a context like Northwest Syria, where there aren't the universally identified and agreed governance structures or institutions to hold that evidence or data. So that's where there's a challenge. But again, I think that's a lobbying of donors who are often would have access to a lot of that data if it's not held within some of the local institutions.
Okay, thank you. Mazen, and I want you to focus a little bit about the role of local actors in this dialogue or in this cohesion. Yeah.
Yeah, okay. I will also reflect on the ownership of data, which I believe, unlike the private sector, because we're not driven for profit, I personally believe most of the data collected in conflict areas and conflict zones should be open sourced. In other words, that this data doesn't actually belong to the INGOs or NGOs are collecting them. They should belong to the population that they collect that they participated in this. We have a similar experience in our group at LSE, CCRG. So we have a mapping project where we try to map different. Try to map what's happening in, for instance, in the education sector, the number of schools that are currently running, destruction level of destruction, and we try to keep them up to date as much as possible. And we actually put all of our data on a specific website called Mapping Syria, where anyone could actually use the data that we collected, because we thought that these data, they don't belong to us. They belong to the people, and they belong to everyone who wants to do something about these data. And we're trying to encourage more and more NGOs and INGOs to do so. The UN, they share most of their data, but they don't share all of them. But this, I don't like to give any credit to the UN, but in that sense, they have open data and they have open data sets as well. But when you talk to an INGO, for instance, and you say, how many camps do you think need, for instance, WASH programs? And they say, well, this is our data. It doesn't make any sense. I mean, this something should be in the public and in the public sphere, right? So everyone can use that. So I believe that if we are collecting data on people, this data belongs to the people, not to the INGOs or NGOs or any academic institutions. Unless they want to make a profit out of it, which shouldn't be the case in our kind of in our fields. How the locals could do that, I think in Syria actually it's now happening. So in Syria, so there is something now, I call it the questionnaires fatigue among Syrians. Every time we try to do any research now in Syria, it's like, oh, not another questionnaires, man. Like, oh, come on. Every Syrian in Northwest Syria, I think, had like 8 different questionnaires presented to them each month. And they're trying to say, now they're asking these questions. What are you going to do with this data? Well, we need to know what's going to happen to this data. And they started to ask questions about the reports, who are funding these reports, where are they going? And I think this is a good start, working with local actors, that this data is your right. And you should always seek. You should always know where your data is, how your data is being used. In addition to having this open sourced materials, and I would also reflect on what our colleague Thuraya said, is also including local participants in a feedback loop. So don't just collect data and publish reports, try to get their feedback and see if this is relevant or not. And this could start also by stop calling these people beneficiaries, as if they have no agency whatsoever. No, they're not beneficiaries. They're participants, and they have agency, and they know what they want, and they know how to achieve that. And when we think of them as people with agency, not as beneficiaries, I think then we can know that they have an ownership. They own these data and they own this knowledge, not us.
Thank you, Mazen. So I would like now to open the floor for questions from attendees. Please, if you have any question, just raise your hand. Yeah, please.
Thank you. Thank you very much for your really inspirational answers. I just would like to share something that I really have to share in response to what you were saying now, the ownership of the people. Basically, my master's dissertation was focused on vulnerable populations in Jordan. So basically what I used to analyze is data from a project that is Global Adolescent Gender Evidence, which is a longitudinal project. But I used like cross-sectional data, and I looked at the interventions that are focused on adolescents, not only Jordanian, but also Syrians and other refugees. So basically, long story short, in terms of resilience and educational outcomes for those adolescents, all the interventions that are done by the UNICEF, which are really, which look really nice, like Hajati, which is cash transfers in exchange for the parents to send the children to school. Or Makani, which is like a space for adolescents to gather and have like a sense of community. Basically, when doing regression, looking at resilience and educational outcomes for those adolescents, the Makani and Hajati are not significant, but what was significant was participation in Quranic classes, or basically having that sense of community cohesion, going to religious activities. So that made me think about like how really blind we might be looking at those communities. They have their own strengths. Just let them be as they are, because you don't need to just find things that, like fancy things that would work elsewhere. So yeah, thank you very much. And I'd really love to go forward with these ideas. But as everybody has been, shedding light on funding and the availability of like the tools within our hands, we don't have the tools. Like if I want data, where do I get it? And so many obstacles. So I hope that with your efforts and with more and more and more efforts, this can be overcome. So yeah, thank you very much. I just wanted to share this insight.
Thank you. So, Zaki.
Thank you. For the feasibility, just one question about the open source, because I hugely advocate for open source data, and it's extremely important in terms of conflict. As you have said, part of the researchers work in the diaspora, and that's very important to make that link and connection between all the partners and all the parties who are taking place or who are taking part in this research. But, and as of experience, because after the earthquake, we have worked on data collection from different resources and from different platforms to localize and map the needs and assess these needs, and to map the emergency response. What are the challenges that come with open source data? And I think, and I'm particularly think about data protection and data safety and so on.
Yeah,
of course, we need to have a long discussion amongst academic institutions and about open sourcing data. We need to adhere to the policies, as you said, for protection some sensitive data. Some data cannot be published. That's something understandable. Any data that could bring any harm to any community or individual should not be published. Any identifiable data or about IDs and personal IDs and all of that should not be published without the informed consent of the people who actually gave these data. So of course, I mean, we have to respect the privacy, a lot of policies and procedures about which data to be published and which data should be protected. But for instance, I would say the number of schools in a certain area, or number of camps, or number of available health services, these should be available as long as they don't create any problems. I'll give you an example. Sometimes sharing data could create lots of issues. So in Syria, we had something called the deconfliction mechanism, which was implemented by the UN. So basically, they said for all medical organizations that if you share with us the coordinates of hospitals and all of that, we will share it with the rest of the warring parties in order to avoid them. What happens is the exact opposite. What happens is that a lot of these hospitals, after they shared their coordinates, were exactly hit by Russian and Syrian regime warplanes. Fortunately, Tamam is not here with us. The most courageous organization back then was MSF, which is also doing great work in Gaza right now. They also in Syria, they said, we will stop sharing our data and coordinates with the UN because they're sharing it with the Russians. They were very clear about this. So they were very clear about which data to share and which data not to share. So we have also to be careful about this thing. So I'm not saying we share all of the data, but we share the most significant data that could actually benefit other organizations and other humanitarian health or other actors to create some sort of concrete actions, while of course respecting all of these long lists of ethics, consent, and other kind of sensitive data.
Yeah, thank you very much for this very interesting discussion, Louise and Mazen. Actually, I have two questions. The first one is for Louise. You mentioned that you are trying to advocate among the donors for partnership with locals. I would like if you could elaborate more on how you're trying to convince donors to accept partnership, serious and genuine partnership with local. What are the interests that they have in this partnership? Because they have the money, they have the power, they're just trying to, marketing their countries by supporting projects in this with the locals. So how you're trying to convince them that they are partners, they are not projects. And my question to Mazen, thanks so much for advocating for the decolonization of the knowledge production. But how can we institutionalize the decolonization of knowledge production? Because as individuals, okay, we can support the decolonization of knowledge production, but we ourselves, we're working in Western institutions. Yes. So how can we institutionalize this decolonization of knowledge production? Thank you.
Just to respond to that first part, I think I was saying that's something we certainly should do more of, to advocate for donors to make sure that any programme they're supporting has been always based on what the local partners, local institutions, national institutions are wanting and needing and agreeing with. But in terms of how to do that, I think you're right, it is a challenge because the motivations of some of the donors aren't always necessarily I'm sure most of them do have the aim to bring about long-term sustainable change and improvements. And ultimately, hopefully, most of them you would hope, wouldn't you? And I think it's really emphasising and demonstrating how that's only really brought about by strengthening and building those national institutions, those national capacities. And that won't be done by disempowering or somehow reducing the role of those institutions. See, those that don't have that ultimate aim, that's a much more challenging context. That's probably where we need to reflect on whether or not we should take money from those sorts of donors that don't have that aim at their heart. Yeah.
Mazen?
Yeah, thank you, Zaki. Thank you, Zaki, my dear colleague, for that question. Yeah, it is very difficult. So, but I think if we take it step by step, we can create a longer impact. So, the first step at the policy level, as I said, is lobbying our institutions, our academic institutions, to adopt a duty of care policy for the local researchers, and by, as I said, acknowledging them as co-authors or co-producers of knowledge, and by protecting them as well. Hoping that they will one day be also considered to be part of this research and academic institutions. They can have good contracts and compensations. So I think a duty of care of local researchers is a good step. It's promising, as you know, that we managed to do so in our unit, and I believe there is now kind of an appetite at a wider level to advocate for this, to lobby for this, and I think the decolonization movement in the UK is very, very strong, and you can see its impact now with the student movement to support Gaza. I think that's one of the main tangible outcome of what decolonization of curriculum actually looks like in real life. So I believe starting from a policy level is important, and also I think academic institutions should encourage participatory research methods. For instance, I did my master's in Sussex IDS, so the Institute of Development Studies, and they have a master program called MAP, Master of Active Participation. And in that master, actually, a huge bulk of that master is how to create participatory methods, or they call it action research, where your beneficiaries became part of a feedback loop and part of the knowledge production, and they've been doing amazing work on this kind of methodological approach to participatory research. And I think focusing on this, adopting some of that, opening the conversation on this is also very important in order to have this participatory methods as kind of as the baseline for every research that we do in conflict areas.
Thank you, Hamze. Yeah, please.
Oh, hi, thank you. Thank you for your thoughts in the panel discussion. It's been really interesting. One thing I wanted to ask is particularly about that. So I think you mentioned that you've been there for 19 months. Is that correct? And that you initially started by framing your operations on the work that you've done in other regions. I'm just curious to find out how the situation in northern Syria, what the biggest challenges are that you faced there, and what your approach has been to that region that's different to some of the other places that you've worked with. Thank you.
So I think some of the main differences are well, the insecurity, which we have in some of the other contexts we work in as well. So Myanmar, Somalia, and there's insecurity. But I think the specific difference, I would say, in northwest Syria is the governance structure, or the lack of an agreed or universally agreed and established governance structure. That's the major difference from any of the other contexts we work in. I think there are examples and learning we're taking from other contexts to understand how to work within that context, but I think that's the main difference. But I think in terms of understanding how we can therefore add value, it's very much by really engaging with the local institutions to understand what that governance structure consists of, recognizing it's very different to anything else any other context we've ever worked in, but making sure we've tried to understand it as well as possible, so that as we're working within that context with those local partners, we're doing so in the way that's going to bring about hopefully the best possible outcomes, but also prevent harm, because we know that it would be very easy, by taking a wrong step, to very easily cause harm by some of the interactions we might have. So I think we've still got lots to learn, so we're very much on a learning curve in this process. But the first thing we did actually in this program, and Dr. Munzer was part of this as well, was undertake a scoping exercise to understand the context of postgraduate medical education. So we really gave us a good basis to be building any future work on. So that was the first step. Thank you.
Thank you, Louise. Thank you, Mazen. We're almost done. Do you have any final question? Just one question? Okay. No question.
I really encourage. Okay.
Comment here, please. The last comment here.
Actually, just to go back to participatory approach, because I think it's very important. And from my experience, actually, I worked with Dr. Munzer when he was in the Northwest Syria during COVID. We did a participatory COVID modeling. And it was very important. I would say, like with any model, like, I mean, if you don't collaborate with the institutions, there is the outcome, I mean, because who will be like implementing? So the translation of research won't happen like on the ground unless you collaborate with the institutions or local partners. And this is why I would say like it was successful with lots of challenges, our experience working together at that time. And then, but there is a big challenge in like also collaborating, like for instance, if you think on the level of patient participation or like even like working with local researcher, like for instance, in our current work on breast cancer in the northwest of Syria, we couldn't compensate data collectors who did massive, amazing job because of like some finance restriction. And like, it was like part of like, some of them, they worked voluntarily and because they were motivated to research, and it was important there and valuable, their contribution. But then with these finance restrictions, sometimes it's really hard like to establish really meaningful and like, I think fair, I would say, collaboration. So yeah, I think.
Thank you, Manar. Thank you, Louise. Thank you, Mazen. Thank you very much for joining us, and thank you for all of you. Finishing statement, 2 minutes, and after that you can go to lunch. So, ladies and gentlemen, as we conclude the 5th Annual Research for Health in the Syrian Conflict Conference, I am grateful to each of you for your contribution and presence. A special thanks goes out to the practitioners and researchers who joined us from within Syria. Your on-ground experiences and insights are invaluable and serve as the backbone of our discussions and our collective understanding of the challenges faced in conflict zones. I would also like to express my appreciation to our hosts, King's College London and the London School of Economics and Political Science, in addition to the entire organizing committee, R4SSS, Awesome, MIHAD, Syria Research Group, Syria Public Health Network, and the Syrian Researchers Volunteers. The knowledge produced here, specifically linked to the Syrian context, holds significant potential for broader applications as we explore similar conflict-affected areas like Gaza, Sudan, Yemen, and Ukraine. The findings and strategies discussed can significantly contribute to shaping resilient health systems in the face of difficulties, with emphasis on the localization agenda and decolonization of a humanitarian aid, including whether you participated in person or online. Your engagement and dedication inspire hope and drive change. Let us continue to collaborate and innovate using the knowledge shared here today to foster health and peace in regions most in need. Thank you all once again. Thank you very much.